Education and Patient Engagement at the Melanoma Research Foundation. Really happy to see all of you here. How are we doing today?
Good.
Good. Ready for a good day of education, learning, and connection?
Yes, ma'am.
Awesome. Well, I've already learned a little bit about Raleigh, and I already had sweet tea, so I think I'm good. So starting off this Monday, great. So thank you all for being here. I'm going to share a little bit about the Melanoma Research Foundation and what we do and how you can get involved. Of course, you're already involved because you're here at one of our education programs, but please know that this is an informal event. We hope that you feel comfortable sharing, asking questions. Of course, Paula said we will have time for questions. Feel free to stand up, stretch if you need to. We also have a room, I think a little bit this way. If you need to take a step away for yourself, please feel free to do that at any time. This meeting will be recorded, and we also have virtual attendees, but you will be able to watch it back afterwards. I'll send out an email with the link so you can watch it on YouTube. So if you missed anything or want to hear something again, go back, you'll be able to do that. And for the virtual attendees, please add any questions you may have to the chat function of Zoom. I would like to start by thanking our Patient Symposia Series sponsors, some who are here today. We have Merck, Novartis, Bristol Myers Squibb, Pfizer, Genentech, Castle Biosciences, Iovance Biotherapeutics, Regeneron, and Immunocore. Without them, we could not be doing all that we do, so thank you to them. And some are in the room, so please say hi and ask questions if you have them. I'm going to share a little bit about the Melanoma Research Foundation. The MRF is the largest independent organization devoted to melanoma, committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. The MRF also educates patients and physicians about prevention, diagnosis, and treatment of cutaneous melanoma and the melanoma rare subtypes, including ocular melanoma, mucosal melanoma, pediatric, adolescent and young adult melanoma, and acral melanoma. The MRF is a dedicated advocate for the melanoma community, helping to raise awareness for this disease and the need for a cure. The MRF website, melanoma.org, is the premier source for melanoma information. We were founded in 1996 by a patient, Diana Ashby, who was diagnosed with melanoma after a 3-year battle with melanoma when there were really not a lot of options out there for new therapies and clinical trials. So she wanted to make a change and rallied her family and friends to raise money for melanoma research. Our mission statement is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. Like I said, we have 3 pillars: research, advocacy, and education. And today you are here with us at an educational event. Our footprint today, we are national. We're headquartered in Washington, D.C., but our footprint is national, and you can find us all across the country with lots of different types of events and supportive resources for patients and their families. We have 17 5Ks, 5K run walks, in cities across the country, 2 signature galas each year, about 7 patient symposias like this one. We bring patients and caregivers to DC, to our capital, to talk with congressional leaders about what is needed and why more funding is needed for melanoma. We have pediatric and young adult events. We host patient symposia for the rare melanoma subtype community, and more. So here is a snapshot of some of the research that we are funding right now. In 2023, we awarded 31 grants and have funded over $25 million in research. I just want to say one more thing about our research program is all of our research that we find is peer-reviewed, and we also have advocate reviewers as well. So if that's something you've ever been interested in reading proposals that we get, we always love the patient and caregiver perspective to review our grants as well. So let us know if you're interested in becoming an advocate reviewer. In terms of our education program, we have educational materials which you all have in your folders, and there were some on our welcome table, but take a look at those. That's just a little bit of what we offer, but on our website we offer materials that doctors' offices, dermatologist offices, fundraisers, or high schools can order our materials, and we get orders all the time. I think last year we got like 44,000 educational material requests, physical pieces of information and literature. So we're spreading it out there, and we want to continue. So let us know if you'd like more educational materials or to bring it anywhere that you may like. We have webinars monthly. So this month is Melanoma Awareness Month, and we are having a webinar this week on May 22nd, virtually 1 hour from 7 to 8 p.m. on sun safety, early detection and sun safety. We do one every month, so catch us online. We also have animated melanoma patient videos. You can go on and learn about TIL cell therapy, clinical trials, diagnosis, all of those things in these short, easy to understand animated videos, and more. You can go on our website and see our Education Institute, which has all of the videos from all of our past events that you can go back and watch, our educational materials, and our animated patient videos. Like I said, we have 26 pieces of literature available, so take a look, and it's all downloadable online as well, so you can download it to your computer and even print it home. We have 64 on-demand videos that you can watch as well. And here's just some pictures of our past Ask the Experts. These are our webinar series. So each month we do a different topic. This one was an oncolytic viral therapies, the current state of immunotherapy, and the last one was TIL cell therapy. So you can go on and watch these because they have already happened. We also have a patient and community forum. Does anyone here know that we had a forum on our website? Yeah. So it's a place where you can go on, it's a discussion post just for melanoma topics. So if you have questions to other patients, people are on there communicating all the time, almost like a Facebook page, but more specific. So conversations range from different topics such as new therapies, how to talk to children, how to talk to grandchildren, new FDA approvals, all different types of topics. So you can go on there and ask a question to your fellow patient. As I mentioned before, every year we bring patients and caregivers to Capitol Hill to meet with congressional leaders. We also work with legislators and policymakers to help increase funding for cancer, specifically for melanoma research. We just held our annual advocacy days. Has anyone been to our advocacy days before? Okay, we got to get you guys to the Hill. We have it every year in March during appropriations season, and we had it in March this past year, but if you'd like to attend next year, please reach out and I can connect you with our advocacy director on the many important topics that we bring to the Hill. We have our prevention and awareness campaigns, which are virtual campaigns. Several of them are up here. Our new spokesperson for our hashtag Get Naked campaign. Our Get Naked campaign encourages everyone to do monthly self-skin exams and go to the dermatologist once a year. Our new spokesperson for this year is Miami Dolphins running back Raheem Mostart. And as I said, Melanoma Awareness Month, so we have a lot happening this month. So follow us on Instagram and TikTok and social media, and you can see all the things we're doing for bringing awareness to melanoma this month. We have our Spot the Dog campaign, which is at the bottom, which is for pediatric melanoma. I Get Dilated for ocular, and Out of the Shadows for mucosal melanoma. We have some exciting cutting edge programming, which can be found on our website, again, melanoma.org. And then I want to share a little bit. These are all of our social media handles, so you can follow us or tag us if you take a picture today. But we'd love to have you join us on our community online. And of course, at the MRF, we're dedicated to advancing the scientific understanding and treatment of melanoma. Every individual contribution is vital to our mission. Thank you again to our Symposia series sponsors. And we're going to get on with the show. One more thing I want to say is at the end, I'm going to show a QR code. A QR code with survey, so you'll be able to do that at the end. Or again, like Paula said, it's in your packet, so please make sure to fill out the paper copy and make sure it gets back to me. Thank you, everyone. I'll be here over here if you have any questions.
Thank you. All right. I was remiss, I did not acknowledge and introduce Trish Long, my partner in crime over there, who preferred not to come up here. She's a nurse practitioner with our program, and she's a vital part of today's event. I'm very grateful and honored to welcome Dr. Shweta Sukla, Assistant Professor of Dermatology here at UNC Hospital. And she's going to educate us, and I'm really appreciative because she's a very busy person, so thank you for coming.
In the meantime, while we get the technical stuff sorted out, very nice to meet you. I'm an assistant professor in the Department of Dermatology. I see patients over in Southern Village and then also in Hillsborough, but I'm very excited to be here today to talk to you all about just skin cancer and sort of prevention, what can you do, and sort of what are the things, perfect, thank you so much, what are the things that when you're worried about a spot or a skin cancer, kind of what is the process that you have to go through as a patient? Because it's pretty nerve-wracking to go and kind of not know, what's going to be done, like how are these things done, and sometimes it can be very helpful to sort of have an idea ahead of time of what are the sorts of things that are done, what should I expect, and it can just make the process better for everyone. So I'm hoping to talk about that. So I guess starting with what is skin cancer. So this is a melanoma conference, but just sometimes it's helpful to know because all these terms get thrown around, but I like kind of just going back to the basics and let's see if I don't. There we go. Okay, everyone see that? Okay. So skin cancers are usually an abnormal growth of skin cells. It's most often caused by accumulation of UV radiation or sun damage. And really the type of skin cancer you have is determined by what kind of skin cell grows more. So this is kind of how our skin looks under the microscope. It's made up of several different layers, and there are something called squamous cells. There's something that are kind of more towards the top layer of the skin. There's something called basal cells, which is kind of, they almost kind of line, sort of this line of cells here towards the bottom of the epidermis, we call it. And then we have melanocytes, which make melanoma. So when there is growth, So when there is growth of these squamous cells, we call that a squamous cell skin cancer. Then when you have this kind of bottom layer of cells here that grow more, we call that a basal cell skin cancer. And lastly, you see this little kind of brown cells. Those are the ones that make pigment. So the point of pigment is to kind of help protect us from the sun. So when those overgrow, that's when we call it melanoma. So skin cancer is very, very treatable. That's the main thing. If it's caught early, it's caught on time, it can be very treatable. And if we're good about sun protection, it can kind of help prevent that. So just to go a little bit more over, I wanted to go over each of the different types. What are some signs? How can you recognize them? Just so you know what to look out for. Because the one thing that is great about the skin is that we can kind of always take a look at our skin. We know what's going on with it. So basal cell skin cancer is the most common kind of skin cancer. So it can look a little bit like a skin-colored bump, kind of the same as your skin color. It can look reddish. It can look, there's the pointer. Okay, there we go. It can look like a little red patch. It can have kind of this flaking and scaling on it. And usually it will develop after many, many years of sun exposure. Sometimes, you know, if someone has a history of going to a tanning booth, tanning can kind of increase the risk of this kind of skin cancer. Also, if you have fair skin, if you have red or blonde hair, those things can kind of increase your risk of getting the skin cancer. It's more common kind of on the head, neck, arms, so we're kind of thinking on areas that tend to get more sun, but we really can find it sort of anywhere, so it can be on even the chest or the back or other areas that may not get quite so much sun. This is the kind of skin cancer that usually does not really metastasize anywhere. It kind of grows in that same area. It can, you know, get bigger and bigger over the time, so we can say that it can kind of be destructive to that area. It can grow into nerves, or if it gets really big, it can grow deeper down into bone. But again, if it's caught early, it's very, very treatable. So the next kind of skin cancer is squamous cell skin cancer. So that's the second most common. This one looks a little bit more like a red patch, and it has a little bit kind of more of that crusty, scabby stuff on it, right? Compared to the basal cell looks a little bit more shiny. It might just look like a little pink spot that you may not even notice. This can kind of have more of that scabbing, crusting. You know, you might not be sure, you might think you might have had a little like injury there. It can sort of, you know, open up, it can be a sore, and then the sore will heal up, and then, you know, a couple weeks later you realize the sore or the scab is back again. So those are kind of the things that we want to keep an eye out for. Similar to the basal cells, it can also be more in areas of sun, so like the tops of your ears, forehead, really nose, but again, most of these skin cancers, you can really find them anywhere, but those are more kind of the common areas because we're kind of out and about all day. Our face areas or arms, those are areas that tend to be exposed a lot more. And finally, the last one is melanoma. This is the one that, you know, we kind of say is the most serious skin cancer. It's the one that we worry about most because it has more of a tendency to spread, so it can either develop in a mole that you might already have, or oftentimes it can actually just develop on an entirely new spot. So it doesn't necessarily mean that it has to come from a mole. So the thing with melanoma, we love to do education for all these skin cancers, but especially for melanoma, because if we catch it early, it can often just be treated by cutting out, and it can really kind of help prevent more of that, you know, like getting bigger, spreading to other areas if we're kind of catching it early. This tends to kind of have more of that brownish color, so the mole might either kind of have an abnormal shape, you might get other colors in it, so you might get kind of that in a bluish color, it might look kind of really, really dark brown somewhere else, you might kind of get a red area. So this could either be a mole that you already have that's changing, or it could be that you get like a brand new spot that is starting to look like this. So anytime I tell my patients, anytime you get something new on the skin that's changing or growing, come on in, let's take a look at it, because spots can change, spots can grow, so we always kind of want to keep an eye on what's going on with our skin. Okay, so what do we do? So let's say you kind of notice the spot. What's the process when you go to a dermatologist? Like, what happens in the office? Some of you might be familiar with that, but just going to go over the kinds of procedures that you can have to take a sample to figure out what is going on. So usually you'll come into the office, if we see a spot that we're worried about, we'll say, hey, why don't we take a little biopsy, a skin biopsy, or a sample of this to figure out what's going on, and we will send it to the lab. there's a couple different kinds of biopsies that can be done, which is a little bit more nuanced, but for all intents and purposes, they kind of all have generally the same process. So first, usually we'll use like a local anesthetic, usually lidocaine or novocaine. It's the same as what you usually get at the dentist, so they kind of use the same local anesthetic. So we might want to know if you've ever had any reactions to local anesthesia. That is helpful to know. We will numb the area. I tell my patients this is really the worst part of the procedure. If you can get through the numbing and the poking, like, you are not actually going to really feel it for the most part when I take that sample. So what the numbing does is it makes you, it'll help you not be sensitive to pain, but you are actually, during a procedure, you might still feel a little bit of tugging and pulling. That's normal, but our goal is for it to not be painful for you and for you to not feel kind of any sharp sensation. The whole procedure usually takes about 5 to 10 minutes, with really the worst part being the numbing. So the first kind of biopsy, one of the biopsies that can be done, and this is the one that we most commonly do, is called a shave biopsy. So essentially, we take a little tool and we call it, like, it's a little bendy razor blade. It's basically a razor blade. It has a little plastic kind of attached to it, and we can kind of bend it. It's very flexible, so it kind of helps us move around the skin. But once we've numbed you up, we will take a look at the spot, and we'll take our little bendy, trusty tool, and we kind of go underneath the spot, and we kind of scoop as much of it off as we can. Depending on what kind of spot it is, it'll be slightly different. If it's a really large, skin cancer, our goal with the biopsy is always to remember the goal of the biopsy is not to take the whole spot away necessarily. It is just to get a sample that's big enough for us to figure out what is going on and what will be the best treatment for you. So that may sometimes, if the growth that you have is small enough, we can often with the biopsy take away all of it, or take away as much as we can see with our eyes. Sometimes if it's a little bit bigger, we'll just take a little small area and see what we can do with that. So another kind of biopsy is something called a punch biopsy. So this is kind of say it's like a little cookie cutter type tool. You know how you, like, if you have cookie dough and you try to cut cookies. So it's like a little cylindrical tool where the purpose of this biopsy compared to the other one is we want to do this to get kind of deeper into your skin. If we see something on your skin that we're a little bit worried about, we think this might go a little bit deeper, let me try to get a little bit more, your dermatologist might want to do this kind of biopsy instead. But again, it will be the same thing. It'll be the same numbing medicine. It'll just be a slightly different tool that we use, and it'll just give us kind of more layers of skin to look at under the microscope. And this is the last kind of biopsy. So this is the biopsy that we use least commonly or least often. It's the one that I do almost rarely, never. But it is important in some cases. So if we have, if you have something on your skin that's a little bit bigger, that we think it would actually be very helpful for the pathologist to look at the whole sample rather than just part of it, and it would give us really good information, then we opt for something called an excisional biopsy, where we actually just skip to like kind of an actual blade and we take out the whole lesion or the whole growth, and that way the pathologist can kind of look at everything under the microscope, and that is often helpful for if we're trying to plan like a specific treatment. It might inform us about that. It might kind of inform us, well, how deep does this go? Like, is this something that we have to worry about? If it's, could be something that would go to your lymph nodes. It'll just give us a lot more information. This is one that we tend not to use because most of the time we can actually get a lot of good information from the other two kinds of biopsies, but kind of if you go in for a worrisome growth, typically this is one of these three things is what's going to happen, and usually it's really mostly the first one. We're just kind of take a little scrape of your skin basically. Let's see, so then after that, pretty much most of the time with these biopsies, you don't even really need stitches. We can often just leave it open and it'll heal in. We'll usually recommend really good wound care if we want to have a nice, pretty little scar. Usually we'll want you to keep it covered with Vaseline, keep it moist so that the scar heals in nicely. When wounds are kind of left open to dry out. They can kind of crust over a little bit and they don't heal quite as nicely. Sometimes if it's one of those bigger samples and we have to take a little bit more, we will have to put in stitches, but again, that'll just be a couple more minutes. We'll put in some stitches and again it'll be kind of the same wound. Sometimes we can give you either like a little suture kit to take out the stitches at home by yourself if you feel comfortable, or we can have you come back to take out the stitches. So what happens after this? So after this, the sample goes to the lab, they process it, and there's someone called a dermatopathologist usually that will look at the tissue, and they'll essentially prepare slides of the sample. They'll look at it under my microscope and kind of can really see what kinds of cells are growing, like we talked about at the beginning. So whether, is it like squamous cells that they're seeing? Are they seeing like basal cells, or do they think that there could be like a melanoma growing or melanocytes growing, which make the melanoma? Once they look at it, they sort of give us their report, and then we work together with the dermatopathologist. And a dermatopathologist is usually a dermatologist that has trained, and they do extra training to do this, to look at specifically this kinds of tissue. So they sort of have that experience from when they have seen patients to sort of know what these things mean under the microscope. But we sort of work together with them to figure out, what kind of skin cancer is growing and what kind of treatment would be appropriate. So at that point, usually what we will do is we'll kind of look at that report and we'll sort of think about what are the different options. So what I'm going to go over are a couple of different things that we do in the clinic, procedures to treat these skin cancers. I know later Dr. Colicchio is going to do a talk on kind of more of the medical therapies in melanoma, but I'm just going to talk about the few that usually you would be coming back to the dermatologist's office for. So there are a couple procedures. So the first one that I wanted to talk about was electrodesiccation and curettage. So this is really, we call it kind of the scrape and burn procedure. It's like sort of a quick and dirty procedure to get rid of skin cancer that's in the top layer. Most of the times, it's done for the basal cell skin cancers and it's done for squamous cell skin cancers. This isn't really something ever that we would do for melanoma. Because basal cell skin cancers and squamous cell ones, if you remember, are the ones that typically tend to be ones that we don't worry so much about spreading other places. So they tend, if the kind of skin cancer you have is a basal cell or squamous cell, it's in the very top layer of the skin. So when they look at things under the microscope, the pathologist can kind of tell us, hey, is this kind of in that top layer? Or hey, I think this is growing a little bit deeper down. And so when we look at that report, we're able to know. And if it looks like it's in the very top layer, it's very early, maybe it's not been growing so long, we usually think that we can actually scrape away. We have a tool called a curette. We can sort of scrape away the skin cancer, and then we use a tool called electrodesiccation, where we sort of kind of burn the area to stop the bleeding and kind of destroy the rest of the skin cancer cells. So what we actually do when we do this procedure is we can feel the skin cancer with the curette. We can kind of, the skin cancer tissue just feels a little bit more like mushy to us, so we're able to kind of scrape it away and know when we're, when your skin feels normal. So this is a great procedure. I really like it for patients that are like, hey, I don't want to do too much. I don't want stitches. I don't want major surgery. Doc, is there something that we can do that just, wouldn't be so involved? This is what I'll usually recommend. Because it's, it's in the office, it'll be the same. We will numb you up, we will take our tool and we'll kind of scrape it away, and we'll, keep going until we get to a point where we feel like there's nothing there, and that's it. And that's it. And then we do Vaseline, and you kind of heal your wound the same way that you would if we were doing the biopsy. This is a really great procedure. For the right kind of skin cancer, it has really great cure rates. Most of the time, these skin cancers don't come back if we do it on a skin cancer that is in the top layer of your skin. So next step up after this that we do, let's say we look at the report and it's either a basal cell or squamous cell, or for melanoma. So most oftenly this is it's called a surgical excision. This is what we would be going to do if you have a melanoma. This is where, we don't think scraping is a good idea because we want to really get everything. So when we do a surgical excision, again, it's still in the office, you still come in. This is a longer procedure, so this would take more, maybe about an hour is what we tell patients to budget. You come in, we'll numb you up the same way. You probably need a little bit more numbing medicine for this procedure because we're trying to cut away some more skin. And so the dermatologist will take a blade and essentially they'll look at where the biopsy was done, or they'll look at where the leftover skin cancer was, and they'll kind of cut like a large sort of oval around it, and they'll kind of leave a little rim of skin that looks normal, because our goal is to just kind of take away as much as possible. And then what they'll do is they'll kind of cut a little bit deeper down, so you'll have a larger wound. And the goal of this is just to kind of get a lot more out, because we want to make sure we are getting like everything out and there isn't really anything left over. And for this kind of surgery, usually you will need stitches because it is a bigger wound. And usually it'll end up being a good 4 or 5 inch scar, depending on, how big the actual original skin cancer was, and you'll kind of have a line for a scar. So this is a little bit more involved, but we like this compared to the other procedure where we just scrape things, because it's a little bit more, we can feel a little bit more confident and sure about, hey, like I got everything out. And what's more is then we can kind of send everything we cut out, we'll send that to the lab again, and they can look at it and they can check and they can be like, hey, like everything looks like it got out, like everything looked negative, I didn't see any more skin cancer cells at the edge of it, we definitely got everything. And so that's why this procedure is really great. It just means, it'll take a little bit longer, you might have a little bit more pain or discomfort from it, and you will have to get stitches. And the last one that I want to talk about is Mohs surgery. So this is a special kind of surgery. This is done by someone, a Mohs surgeon. So Mohs surgeons are dermatologists that have done additional training to specifically cut out skin cancer. So what they do all day, every day is cut out skin cancer. And Mohs surgery is a special kind of surgery where we say it's for high-risk locations. So what does that mean? So that means it is for maybe skin cancers that are in more sensitive areas, maybe like your nose, your ears, your lips, areas that maybe don't have like a lot of skin, like any skin cancers that you might have in your genital area, or let's say on your shins, like your shins don't necessarily, there's not too much underneath there. So it's a special kind of surgery that is designed to take away as little of your skin and tissue as possible, but also make sure that all the skin cancer has actually been taken out. So this can be done for all kinds of skin cancer. In certain cases, we also do it for melanomas for patients. So the reason that this is a little bit different, and this is kind of more of our big gun procedure, is that it takes a little bit longer. So usually for this, so we're kind of stepping up here where we had like the scraping and burning, which is a couple minutes, and then when we do an excision where we cut it out, we say budget an hour. For Mohs surgery, I will tell my patients, I want you to budget at least being in the office for maybe either a morning or for maybe an afternoon. And that's because for this surgery, what the Mohs surgeon does is they sort of go in and they take one layer of the skin cancer out that they can see, and they try to get as much of it as they can, and they think, okay, this looks good, and then what they do is they actually go look at it under the microscope then and there. So it's kind of more like they're looking at it live. They go take a look at it and they say, hey, there's still skin cancer here, I didn't get everything, so I'm going to go back and I'm going to take some more out. And in the meantime, what they do is, while they're kind of looking at things under the microscope, they put a dressing on you, you go hang out, you sit, and then we bring you back again, and then they can take more if they need to. And essentially, we kind of keep going, and the process repeats until the Mohs surgeon kind of looks at everything, and he's like, well, no, all the skin, he or she, all the skin cancer's out, there's kind of nothing left here at this point, I can stitch you up. So we want to do this for certain skin cancers, right? Like on your nose, your ears, because there's not a lot there, right? We don't want to take your whole ear or nose off. So when we're doing Mohs surgery, the Mohs surgeon can take very, very small layers of your ear or nose or all of these sensitive locations to kind of make sure that we don't have to take too much away, and that, you know, it will have the best cosmetic result possible, because then they take as little away as possible so that there's more to work with. So when they close you up, it will, you know, look better for you as well, and will kind of remove as little as possible. So in some instances, this is done for all sorts of skin cancers. So that's sort of kind of the last thing that you can expect if a dermatologist, if you're going to have your skin cancer treated in office with a dermatologist. Those are sort of the different kinds of procedures you can have in the office. Kind of getting a little bit more into melanoma briefly. A lot of those procedures I talked about, they're used for basal cell skin cancer. They're used for squamous cell skin cancer. They can also be used for melanoma, but melanoma is kind of a special case, like we talked about, right? We worry about it a little bit more because it does have more of a tendency to spread compared to the other skin cancers. But if, let's say, it's a very early melanoma, so you could still we can still cut it out, like we talked about. If it's a certain kind of melanoma, sometimes we can do Mohs surgery for it. And all of that can still be done in the office for melanoma. And when melanomas are a little bit deeper, or they, you know, spread, that can require additional treatment. So in addition to having it cut out, you might have to have a lymph node checked or a lymph node cut out. And, you know, when it's getting to more advanced melanomas, you might need additional therapy like the immunotherapy or targeted therapy, radiation, but those are kind of, you know, skipping several steps ahead. Usually we'll kind of start with the biopsy, and then once we know what it is, we can kind of decide what treatment would be best for you. And I know Dr. Colicchio is going to talk more about the medical treatment, so in the interest of time, I am going to kind of skip over this, but mostly the big thing is we kind of will start with cutting things out if we can. This is, again, about kind of the checkpoint inhibitors that Dr. Colicchio is going to talk about. I think I really like this cartoon, so I'm going to briefly touch on it, but I'll let her kind of go into the details. But one of the checkpoint inhibitors that we can use for melanoma is called PD-1, and I really like this cartoon, and I just wanted to briefly show it because I remember when I was learning this, I had such a hard time understanding it. I still get confused every time I look at it. Again, I'm like, wait, what does it block? But I really like this. But the immune checkpoint inhibitors just essentially kind of help your immune system fight the cancer. And so they have certain molecules. So if this is kind of your immune system, it's called a T cell. They have something called PD-1 on them. So what the cancer cells can do is they can kind of target that, and that, you know, sort of will, when that PD-1 on your immune system cell, or this T cell that's, you know, will fight the cancer, it gets sort of put to sleep, and the cancer can sort of like run away, and it's, you know, the immune system's not able to fight your skin cancer. So what a checkpoint inhibitor will do is that can be like our medication, our little inhibitor. It'll block PD-1. It'll kind of like protect it so that when the cancer cells kind of try to target that to shut the immune system down, it doesn't get shut down, and it'll help your immune system sort of fight the cancer. So I really like this cartoon, but I'll let Dr. Colicchio go into the details of it. But those are the kinds of therapies that are done for melanomas that are a little bit more advanced. So last thing is just to kind of talk about what can we do to prevent skin cancer. I think this is like the most important thing, because sometimes it's hard. It's like there's only so much that we can do, but sun protection is actually one of the things that we can do. So the big things that I like talking about is making sure that there's like, you can get shade when there is shade. So, you know, when we say like if you're out in the sun and your like shadow is like shorter than you are, it means kind of the sun is very high up. So trying to be in the shade during those times of day. if you can, wear sun protective clothing. So there are actually clothes that are made that will have a UPF, like protective factor in them. So you can kind of look at it and look at what it is, and it'll usually rate it, it's for a certain amount of time that that piece of clothing will have some sort of UV protection in it that you can wear after a certain, after a certain number of washes. You can't wear it anymore, but it's a great option for, if you have a hard time remembering to wear sunscreen. If you're gonna kind of opt for sunscreen, then you want to reapply it. This is the hardest part. You want to really reapply sunscreen every 2 hours, because when you are outside, if you're sweating, it kind of comes off, it wears off, and it just doesn't have that effect anymore. Especially if you're gonna be swimming or if you're gonna be sweaty, it is gonna wear off. So at least like a SPF of 30, applying it every 30 minutes, every 2 hours. And especially if you're actually doing like water sports, or if you're like in the snow and sand, it kind of can seem deceptive. You may think even on a cloudy day, let's say, you may think, I don't really need sunscreen, but if let's say you're out on the lake or something and it's a cloudy day, the water actually reflects the UV light, so you're actually getting even more. So you want to be extra careful and be reapplying sunscreen more. So then I like this diagram from the AAD about kind of how to select it, because it can be a little bit confusing. The bottles have a lot on them, but we want to make sure that it's at least SPF 30. It says broad spectrum, so what that means is it blocks ultraviolet A light and ultraviolet B light. And then you want to make sure that if you're gonna, especially if it's water resistant, that's even better. That doesn't make it foolproof. You still want to put it on every 2 hours. And then the other most important thing is actually, we want to make sure you're putting enough on. So we say to cover your whole body's worth. The AAD recommends 1 ounce of sunscreen, which translates to filling about 1 shot glass. It's funny that they use that as their analogy, but that's what they decided. So it's about 1 shot glass worth of sunscreen is what you need to cover kind of your whole body surface area, which is quite a bit if you try to measure that out. I think most of us tend not to put maybe as much sunscreen as we should on. And the other thing with sunscreen is, the best one is the one that you'll wear. Usually, I know some people really like the sprays, but for instance, the sprays don't give you as much coverage, because when you spray it on, it's harder to really get it over everywhere, and you're not putting quite as much on. So I personally don't love the spray sunscreens, but it's better than not putting sunscreen on. But if you can get one where you're actually it's more of a lotion and you're spreading it in, that will work a little bit better. But again, you can kind of use a combination of stuff, like large hats, especially that'll cover your ears, or a spot that are overlooked, the back of your neck. Other things you should think about are maybe like a chapstick or something. There's Vaseline makes a little lip lubricant that actually has the SPF in it, because you can get skin cancer on your lips. So that's something that can get overlooked, where if you're not putting on something that actually has some SPF in it. So those are some things that I also recommend. Avoiding tanning beds is a big one. We get a lot of people that have been using tanning beds. They really increase how much UV light you're getting, and that can really increase your risk for skin cancer. And just looking at your skin periodically overall, when you're in the shower or after the shower, just if you see any spots that are changing, always go on in, get it checked out. It never hurts. The worst that we'll say is, it's not anything, don't worry about it, but we want to make sure we're catching things as early as we can. So if anything also is changing, like it's bleeding, it's itchy, it just keeps being there, it's just not going away, those are some other kind of red flag things that I like to tell my patients to look out for, and I'll just say, hey, come on back in, and we'll just take a look at that spot. And you have a great handout in your folder, actually, of the ABCDEs, which I love to talk about, but what do you watch out for? It's spots that are asymmetric. They kind of look funky. They're not even. They don't necessarily kind of have smooth edges. So it kind of looks really funny here, or if they get other colors in them, right? They kind of have that like bluish color. It looks like black. There's areas that are maybe like whitish. We want things to look healthy. Things look kind of smooth. They look like even. So if it's starting to look a little bit weird, you're not sure, it's better for you to get it checked out. If it's kind of bigger, so we say if things are getting like big, they're like maybe bigger than like the tip of a pencil eraser size. That's something that we all also say, like, you know, if it's getting bigger, and that goes with kind of the E, the evolving. If things are changing and they're getting bigger, then that's something that should always be checked if you're not sure. You know, sometimes I had someone that came in and told me that, you know, I've had this spot for 20 years, and I was like, are you sure? It just, I don't know, I don't like how it looks. They're like, no, I'm positive, it's been there for 20 years, and I took a sample of it, actually came back as a melanoma. It was a very slow growing melanoma, but just when things are changing, we should look at them. And that's it.
I have a question. How much does immune suppressant drugs affect skin cancer?
I guess that's a complicated question. It really depends on the medication you're on and medication regimens people on. There's certain medications out there that we know when people are on them, it increases their risk of skin cancer, and not all not all medications that sort of work with your immune system necessarily increase your risk of skin cancer. So really, I hate to give this as an answer, but it really depends on kind of like what medication you're on or what regimen that you're on. But certainly for certain kinds of immune, so it's best to probably ask your doctor and say, hey, is this going to increase my risk of skin cancer? And if so, what we do is we'll try to just see people more often or see them every year to make sure that they're, because of any immune-related medications they're on, that it's not increased, that they're not developing any skin cancers.
Thank you so much.
But I'm Trish Long, I'm the nurse practitioner that works with surgical oncology. And I want to introduce next Jennifer Spring. She works here at UNC. She's been a registered dietitian and certified specialist in oncology and nutrition for over 20 years. And she worked with the patients to improve nutrition status and help tolerate the treatments better. So let her tell you more about her role.
Let me see if I can get this here. All right, so today we're going to talk about nutrition and living with cancer. In terms of melanoma, there's just a few little tips that I'm going to make along the way, but most of the information that I'm giving you is going to be talking in generalities in terms of promoting good health, and also potentially preventing future recurrences of cancer or new cancers. So the American Institute of Cancer Research has some really great guidelines. There's 10 guidelines, and today we're going to talk about 8 of them, because they're really specific to the nutrition and the healthy lifestyle. We're going to go through each of these, and if you ever get a chance, I really recommend that you go to their website, because they're going to talk about these points in depth, and then they're going to have also something called a continuous update report, where about every 5 years they're looking at these particular cancers and they're taking all the research from across the world and they're giving new guidelines based on that new research. So it's constantly being updated. So it's a really great resource for evidence-based information. So the first one is be a healthy weight, right? I want you to be really healthy, I want you to be physically active, and that means being a healthy weight and making sure that your waist circumference is, for women, less than 31.5, and for men, less than 37 inches. And the reason is that in this area of our bodies, this is our abdomen, when we have a waist circumference that's large, it's containing fat that's subcutaneous, it's in the skin, and then also possibly what we call visceral fat. Visceral fat is the fat that's around your organs, and that fat is active. It's not just sitting there not doing anything, it's active. It's kind of acting like a pump. It's pumping insulin and hormones, and those kind of things can actually be promoters for chronic disease, including cancer. And so being physically active is really going to be important moving forward to keep that waist circumference healthy. So these are your guidelines. I usually look at the waist circumference over the body mass index just because of that visceral fat component. So part of staying healthy and part of keeping your weight stable is being physically active. And physically active means something to everybody differently, because some people may not be able to go and take a walk. They may not be able to go and run. They may not be able to ride a bike. Physical activity might just mean that you're sitting in your chair and doing, a chair video workout. So physical activity, we have guidelines, and the recommendations are be physically active. Try to get at least 150 minutes per week of moderate physical activity. So that could be walking, it could be riding a bike, it could be playing volleyball, but it could also be sitting, watching a video and doing chair exercises or doing yoga. It could be doing physical activity every day where you're at. Just make sure that you're checking with your medical team if you're in active treatment, or if you're just out of treatment, just check to make sure that you are cleared to do physical activity. All right, or if you're going to be starting a new regimen. The more physical activity you do, if you can do vigorous physical activity, you're going to get more of those health benefits. So the recommendation for vigorous activity is at least 75 minutes per week. So that's not just jogging, that's running. It's doing one of those high-intensity HIIT classes. That's cycling and going several, miles doing your cycling. So be physically active, sit less, move more. Unless you're bound to be in your chair, then do your exercises with your arms. The other thing that I want to mention here on the list is to eat a diet rich in whole grains, vegetables, fruits, beans, nuts, and seeds. This picture here demonstrates that eating a plant-based diet, it's not completely plant-based, it doesn't have to be 100% vegan, is going to give you more nutrients, higher vitamins and minerals, lower calories, higher fiber. All of those things can help to promote a healthy gut environment. I don't know if anybody here is familiar with the terminology, the gut microbiome. Yeah. So our gut microbiome, the lining of our intestines, houses about 60 or 70% of our immune cells. And so when we're keeping that environment healthy with a plant-based diet, we're helping to support that immune system. And so the doctor just spoke to us about the immune checkpoint inhibitors. With some recent research with melanoma patients, they looked at those patients that were eating a plant-based diet, higher fiber, higher, brighter colors, actually had a really great response to the immune checkpoint inhibitors and had increased survival time post-treatment. So really thinking about how can I, in this active treatment phase, if you're in that part of your treatment, really support that treatment that I'm doing. So eating more plant foods, getting more fruits and vegetables. When we look at plant foods, we see lots of color, right? We see bright colors, we see greens and reds and yellows. We see different tastes and different smells. All of those chemicals that give the plants their colors, their tastes, and their smells, those are there to protect the plants. And when we as humans consume those with all those bright colors, those chemicals, we're imparting some of that protection on our bodies. Those are the active compounds that are helping to support our immune system to help prevent our cells from getting damaged. They're helping to actually possibly, even in some cases, stop tumor growth. I just wanted to show this slide. So this just shows you, these are just the tip of the iceberg in terms of looking at the rainbow of foods. And when you're consuming them, I don't know which one this is. I'm going to use my hand, but if you can see on the left-hand side, it says the phytochemicals. Those are the plant nutrients, the compounds, just the tip of the iceberg of the compounds that are in the plants that are providing that protective nutrients. So when you're eating the wide variety of fruits and vegetables with all the different colors, then you're probably going to be hitting and getting all those different nutrient points. So the more that you can take in, the healthier it is for you. And some people say, they ask me when they're coming to visit with me, like, what does that mean, eat more plant foods? So the recommendation is to get at least 5 to 7 servings of plant foods per day. And so if we look at our picture again, 5 to 7 servings. 5 to 7 servings is probably about 2/3, 3/4 of your plate should be coming from plant foods. And that's not just at dinner time, it's at every meal that you're eating. So how can you add more plant foods? How can you get more fruits and vegetables? Not just at dinner time, but in the morning. Instead of just eating that egg, add some spinach, add some tomatoes, right? Have a whole grain toast instead of a white bread. Certainly some people may not be able to eat a high fiber diet if they have certain treatments that are not allowing them to, but when you can, try to add more of those plant foods in. There's not one size fits all in terms of a plant-based diet. It doesn't have to be meat-free. It doesn't have to be just adding green beans and corn. It can be any one of these number. I've put a few different plant-based diets. The Mediterranean is probably one of the most researched. Asian diet, the DASH diet, which is the dietary approaches to stopping hypertension. Vegan, which is completely animal-free. There's no animal products. And vegetarian. Vegetarian, there's many versions of that. You can include dairy products, you can include eggs, you can include fish, some variation of that. So there's many, many popular diets. They're low calorie, high nutrients, they don't contribute to weight gain, and they have lots of vitamins and minerals, and they prevent potential cancer risks. The next point was limiting your intake of fast foods and other ultra-processed foods high in fat, sugar, and starches. So I don't know if anybody has heard this sort of buzzword about ultra-processed foods. I think we hear processed foods, but ultra-processed foods means those foods that really are so far away from their original whole food state that they have multiple ingredients on their list. You don't really recognize what they were originally. A minimally processed food is something like your canned meats, like tuna, or maybe frozen vegetables, where they've had minimal processing. There may be only 2 or 3 ingredients, and those are okay to eat, but we really want to try to avoid those ultra-processed foods. And in this picture, I want to show you something. So here we have on the left-hand side, these are both 1,600 calories. The left-hand side is your fast food, ultra-processed meal. It's not as much food. It's the same amount of calories. There's not a lot of nutrient density, and you may not feel as full from eating that smaller volume of food over the course of the day. Whereas on the right-hand side, you have your plant-based diet, same amount of calories, so much more variety, so much more color. You're gonna feel full a little bit longer. You have the same amount of calories, so you're probably not gonna be gaining as much weight because you may not feel hungry later on. You've got a high fiber, high water content meal, or actually multiple meals. That's your whole day worth of food. So very different. My suggestion to individuals, because it's not always easy to just pull out the unhealthy foods, is maybe find ways to add the healthy foods to the diet that you're already eating. I really love cheeseburgers, right? Somebody says that to me. So how can you make that healthier? Load it up with onion, load it up with spinach or cucumber or peppers. How can you add to what you're already doing without feeling like you're taking something away? So consuming less meat, enjoying more variety, more color from the plant world is really where it's at. The next point on the list was limiting your intake of red meat and processed meat. In the world of melanoma, there's not really a direct link, but in the world of cancer, there is a direct link, potentially a direct link between red meat and processed meat and colorectal cancer. So the recommendation from the American Institute of Cancer Research is not to consume more than 12 to 18 ounces of red meat in a week, all right? And the reason for that is amounts higher than 18 ounces were showing that individuals were at greater risk for colorectal cancer. So that would be the recommendation there. And so here we have that old deck of cards. Palm of your hand is that sort of guideline for about 3 ounces, and you're looking at not consuming more than 3 ounces at a serving time, maybe 4 to 6 times a week. The other reason why we want to not consume as much red meat, or meat in general, is when we cook meats at high temperatures, frying, grilling, and broiling, that process changes the chemistry, the chemical structure of the protein, and that changing of the chemical structure can be a cancer promoter. And also, when you're cooking at those high temperatures, you're creating smoke that's dripping from the fat. That smoke element, that has something called polyaromatic hydrocarbons, that sticks to the meat. Those are potential cancer promoters as well. So you really want to try to avoid those charred, I know this sounds bad, you're going to love it, right? You love those charred meats, but the grilled meats that might have that crispy kind of coating, you really want to try to avoid that. If you marinate your meats in a citrus or vinegar-based marinade, that decreases the polyaromatic hydrocarbons by up to 90%. And the longer that you marinate it, the more you're going to get those beneficial compounds from the citrus and the vinegar. And then I also want to point out that when you're eating these meats, one of the best ways that you can protect your body when you're eating them so that you don't have to take it away completely, right? If you eat those plant foods are going to impart those properties, those chemicals, those nutrients that are going to help to protect your body, so then you can enjoy a little bit of grilled meat, but you're not overdoing it, right? So eat the plant foods at the same time. When you grill broccoli and asparagus, you don't get the polyaromatic hydrocarbons. It's totally not there.
Is that true for fish as well?
That is true for all animal proteins. Anytime you cook the animal protein at a high temperature, it changes that protein structure. And if it's a high-fat animal protein, that fat dripping into the heating element, again, creates that compound, that smokiness. If you use a piece of foil when you're grilling, you don't have that fat dripping off. It may be sitting in the fat while you're cooking it, but you can blot that off before consuming it. And avoiding processed meats in general. Most processed meats are red meats. These are meats that are smoked, they're cured with salt, or they're using a high salt for that process, or they have added chemical preservatives like nitrates and nitrites. There is no threshold, whereas with just fresh red meat, we talked about the threshold being 12 to 18 ounces. There is no threshold for the processed meats. Any amount can increase your potential risk for it being a cancer promoter. So the recommendation is to avoid processed meats. If you can't avoid processed meats, you're on the road, you're going on a road trip, and all you have is Jersey Mike's as your stopping point, that's okay. Remember, we have your plant foods that are going to protect you. So you're going to load that sandwich up with tons of lettuce and tomatoes and peppers and onions and things that are going to help to maybe create that shield and that barrier that's going to be helpful. So don't get too worried about it. All right. When you are choosing animal proteins, if that's something that you want to include in your healthy lifestyle, choosing those that are leaner cuts, that maybe you're eating the white meat over versus the dark meat more often, peeling away that skin, or don't eat the skin after it's cooked. Maybe using a leaner cut, or the tenderloin might be it. You can cook that at a lower temperature because you don't want to overcook it. You're not going to get as much of that chemical change. And then also choosing low-fat dairy if you choose to eat dairy. Animal proteins are very nourishing for our body if you choose to eat them. They provide all 9 essential amino acids, and amino acids are those protein building blocks that we need to help support our immune system and to help heal our bodies. And so they're really actually very important, but you don't have to eat them if you don't want to. They're also a great source of vitamin B12 and also for iron, which are critical for our bodies in terms of keeping our energy level stable. Maybe consider adding more plant-based proteins throughout the week. When you're thinking about your meal planning and eating, adding more beans and lentils and tofu and edamame, eating nuts and seeds in their whole form or in nut butter, adding whole grains. Whole grains are higher in protein than standard refined grains. Really try to sprinkle those in throughout the week if you can. And they don't have to be all by themselves. I mean, they do talk about meatless Monday, but I mean, even if you just do a smaller portion of your animal protein and then fill in the blanks with your plant protein, that would be a great option. A lot of individuals ask me the question about, does sugar feed cancer? Well, that's such a hard question. It doesn't feed cancer. The cells are not looking at, what we're eating in our diet and just gobbling up all the sugar that we eat in our diet. There's an indirect kind of backdoor entrance into that. So eating foods that are high in sugar, actual added sugars. Sugar doesn't have any nutritional value other than calories. It's not contributing to vitamins and minerals. It's not including those plant nutrients. It contributes to weight gain when we overconsume it, and weight and obesity are related to at least 12 different types of cancer. So in that backdoor way, it kind of increases our risk factor for cancer. If we consume too much sugar over the course of our lifetime, right? We're drinking sweet tea every day with every meal. We're eating desserts, 2 times a day, and it's that constant repetitive intake, then you can have high insulin levels for quite a long period of time during your day or your lifetime, and that increase in your insulin level has some ill effects in terms of your chronic health, and it could be that backdoor that could be influencing that. How much is too much? If you are consuming sugar, what's too much? So these are some So the World Health Organization and the dietary guidelines for Americans have a very sort of moderate sort of recommendation is to consume no more than 10% of your total calories coming from actual added sugars. So that would be what, if you're eating 2,000 calories, that's 200 grams. So that's, I think I'm getting this right, like 50 grams maybe of sugar. But the American Heart Association has even stricter guidelines, and that's what I have here. So they recommend that women don't consume more than 6 teaspoons or 25 grams of added sugars per day. And then for men, no more than 9 teaspoons, which is about 37 grams. And so I have some popular sweetened beverages here, and I found out what their content of sugar was. So for a Starbucks 16-ounce triple mocha frappuccino, that's pretty high intensity, that's 51 grams of sugar. So that's twice the amount of recommended sugar in one beverage. Now imagine if you're eating a sweetened yogurt and you're having a granola bar that has added sugar, and you're also consuming a dessert at the end of the day. Now you've maybe tripled your recommended intake for sugar, even beyond the American Heart Association. And the same for just a basic 12-ounce Coke. That has 39 grams of added sugar. I want to point out also that it's not just the sugar-sweetened beverages that can maybe have, maybe not be great for you. So a lot of individuals think that maybe doing 100% natural fruit juice would be a good choice. But 100% natural fruit juice, if you take a 12-ounce serving and put it next to a can of Coke, you're going to see that they have almost exactly the same amount of added sugar, because juice is a concentration of many, many, many pieces of fruit, probably more than what you would eat in one sitting, right? Probably to make 8 ounces of orange juice, you probably need to squeeze about 5 medium oranges, but you wouldn't really sit there and eat those oranges, right? My recommendation would be to eat the one orange and don't drink the juice. And then this kind of harks back to the little shot glass. So the other recommendation is to limit alcohol consumption. There's strong and convincing evidence that alcohol is a contributing factor to at least, I think, 7 or 8 different cancers. Most of those are oral head and neck cancers, and then GI cancers. And so the recommendation is to avoid or limit alcohol consumption. And what does, a portion of alcohol look like? So in terms of the alcohol content, these 3 beverages here, 12 ounces of beer, 1.5 ounces of spirits, or 5 ounces of wine, those all have about the same amount of alcohol content. And so if an individual wants to have an alcoholic beverage, the recommendation would be not to consume more than 2 per day for men and not to consume more than 1 per day for women. And that's quite a bit of alcohol if somebody's drinking that over the course of every day. The other recommendation is not to save all those portions up just for the last weekend and just have them on the weekend, because that actually can increase the risk of some kinds of cancers when you're binging in that manner. So alcohol is a known carcinogen. It damages DNA, and it can promote cancer. And the other recommendation is, a lot of patients ask me, well, what should I take? I need to take, do I need to take vitamins or herbal supplements to help me fight this cancer? And the recommendation is not to take any supplements to help fight cancer. When we take vitamins or herbal supplements, they may be in larger amounts than our body needs, especially when they're not being regulated or monitored by a health professional. And they may actually do more harm than good. And so the recommendation is, don't start taking supplements unless you have a known deficiency, or if there's a reason that in terms of maybe it's helping with your treatment, or mostly if it's just a known deficiency. So like if you have a vitamin D deficiency, or if you have B12 or folic acid for a particular chemotherapy regimen to help reduce side effects, or if you need that because you're already have a deficiency in that. And just a recap of everything right here. Thank you so much. And does anybody have any questions?
Farm-raised fish versus non-farm-raised is it better to, if you're choosing fish?
In terms of what is your question for that?
Healthier.
So in terms of its protein content, they are equivalent. There's no more nutritional value in terms of where you're getting that from. It may not have any additives. If it's wild caught, if it's farm-raised, they may have additives in its food. So you have to look at what am I trying to do? Trying to have less processed additives, or am I just looking to get a good quality piece of protein that I can eat? Whether you cook the farm-raised or the processed, it's in the same heat temperature. You're going to get the same aromatic hydrocarbons and all of the same things. Yeah, so it's a personal preference. There's no greater nutritional value, though. That's not true. So if we look at farm-raised salmon versus wild salmon's going to have a little bit less of the fat content, probably because they're working really hard to get their food, whereas the farm-raised, the food's just given to them, they're gorging, so they might have a higher fat content, so you might have more of that fat content in those cases. Yeah. Good question. I never had that question. I'm in the back here.
So the craze with the pellet grills these days, that's not a good thing, or?
So again, anytime that you're cooking a meat, an animal protein at a high temperature, then you're changing that chemical structure and potentially creating those drippings if it's a fatty meat, and you get that smoking element that sticks to the meat. So if that's something that you enjoy, I'm not saying take it away, but the big message is eat a smaller portion and fill 2/3 of that plate with some kind of plant foods. And that'll help to support that. Or marinate those meats in the vinegars or the citrus marinades for longer periods of time, greater than an hour, and that may help to decrease the chemical compounds. Gentleman in the middle here.
Can you substitute sugar with raw honey?
So raw honey and sugar, when they go in, once you digest that in the system, they're basically gonna act the same way. Honey, I can't remember the exact percentages, has a portion, a little bit more fructose than raw sugar, but it's not that great. So it's gonna act the same way. You're still probably gonna have the same insulin response. Yeah, so I wouldn't say it's gonna provide any, it may provide some magical nutrients, like from the pollen and from the bees, and maybe a little bit more mineral content if it's raw honey. But in terms of how it acts in your body, it's still a product that's gonna raise your insulin level. Yes?
So in regards to like getting everything from your diet and, you know, figuring out deficiencies, is there nutrient testing
We don't normally recommend that individuals go and have, you know, big nutrient panels. I think when you're eating 2/3 of your plate coming from the plant world, and you're eating a small amount of animal or plant-based protein, and you're eating regularly throughout the day, and your weight is staying stable, and you're getting that rainbow and a wide variety of foods, you're probably meeting all your nutrient needs, and you more than likely don't need to have any kind of testing done for that. And those kind of tests that are done are unregulated typically and cost a lot of money.
Thank you, Jennifer.
Thank you so much.
I want to welcome Lauren Lux. She is a clinical social worker with a pretty amazing program we have here at UNC called our AYA program, and it's actually a program that's become, I think, an exemplar to much of the United States. So thank you for coming. Good luck.
So my name is Lauren Lux. I'm a clinical social worker and the director of our adolescent and young adult program. And even though that may not apply to some of you in the room, it no longer applies to me either. It's okay. I think some of the things that we talk about and some of the resources that we have might be helpful to just about anybody. In fact, a lot of people ask me, like, why don't some of the resources and some of the work that you do apply to folks who are older? And honestly, the answer is we have funding and support for supporting this special age group of people. And so, but a lot of what we do, I think it could be really helpful to anybody at any age. So we are supported by a local foundation. Some of you may be familiar with it. It's called the Be Loud Sophie Foundation. I think it's really important to just talk about them and how incredible they are, and just how I think if you are interested in trying to make changes in the medical system, in the world that you're involved in healthcare, you can do that even as someone outside the system, just like this family did. And I think this is a picture that Sophie took. Sophie was a young woman treated for cancer at UNC and unfortunately died as a teenager, but her family decided to try and make life better for teenagers and young adults who are being treated with it and who had a cancer diagnosis at UNC. And Sophie took this picture, and we really like it because the idea that you kind of throw a stone into the water and there's these ripple effects that happen is something that we think about a lot. So again, I think if you're thinking about how you might be able to make a difference, you never know what kind of throwing that stone into the water might actually do. So our mission is to provide age-appropriate psychosocial and medical care for adolescents and adults, and we define that as ages 13 to 39. There's all kinds of reasons for that. For cancer patients and their support communities, and we're really broad with that terminology because young people often, who they have with them in the room and who's important to them looks really different. It might look different for you too, and it's important for us to include anybody who's caring for someone who's going through treatment in the same way and be inclusive of them in those conversations. So we want to advance research in the field of AYA oncology, educate providers about the unique needs of young people, and improve care for AYAs across the state of North Carolina. We have a really big team. There's 11 of us, and we do all kinds of different things, from research to clinical care to sort of how do we make the healthcare system work better and work differently for young people. And essentially what we do is we meet someone when they're diagnosed and we get to know them as a human. Who are you outside of your cancer diagnosis? What's important to you? What's your life look like? Who are the important people to you? And And we learn about how your cancer is going to affect your life and how what's going on in your life is going to affect your cancer care. And our team sits in the middle of that and tries to mediate those things. How can we help you by providing resources, by supporting you, and by really bringing what you need to the table so that you can effectively get the care that you need. And then what we like to say is that we rinse and repeat, because what you need at the beginning of treatment might look really different than what you need in the middle of treatment, towards the end of treatment, and into survivorship. So I think for those of you in the room, that's really important to let your care team know what your needs are and how they change throughout the treatment that you have. One thing that I think is not unique to young people, and we always talk about this, well, I think a lot of us on our team have aged out of the AYA age range. I sure hope that sexual health is still important over the age of 40. And so I just turned 40 this year, and it's still important to me. So newsflash, I think it can be important to a lot of people no matter what your age is. So we have some great resources on our website, and if you want to check them out, I would encourage you to. There are a lot of tips about what is safe to do during and after treatment, and when and how, and questions to ask your care team, because this can be kind of an awkward thing to talk about. We kind of refer to ourselves as the sex, drugs, and rock and roll team. We want to talk about all of this stuff that might feel kind of awkward to talk about with your treatment team. But anybody can check out our website. You don't have to be under the age of 40. There's some good resources on there. We have an advisory board, so if you know a young person who's gone through cancer treatment for melanoma or otherwise, and they want to get involved and help us, our team of young people, really, they're involved in everything that we do. The patient voice and the experience is at the center of all the decisions that we make, and that's how it should be, right? We're not sitting in these chairs, we're not having that treatment. It's really important to include them. We just opened the Be Loud Center for Young Adult Cancer Care, which is an infusion space for folks under 40. Sometimes it's not full, and if you're over 40, you can get a seat in there too. But this was designed for and by young people. So our advisory board built this space. It's on the 3rd floor. This is an example of what's on our website. So ask us about, and there are 5 more rows under this. So we wanted to talk to you about your mental health, about fertility, about financial navigation, sexual health, clinical trials, connecting with other young people, your legal concerns. Basically, we care about you as a whole person. And I know Linnea is going to talk a little bit later about the cancer support that we have across the age continuum at UNC. Because we really care about who you are as a person and what you need, well beyond what your actual treatment is. So I know there's a lot of good stuff going on. I flew through all of that. I'm happy to answer any questions. Please feel free to reach out or contact me, or if you have young people in your life that would benefit from our program, please let them know. Yeah.
I just wanted to let you know, you probably see a lot of high school and college age students. My son's best friend in high school died of non-smoking lung cancer, and he started a golf tournament the year he was diagnosed. And actually was diagnosed with cancer of unknown primary, so he called it the Wager Cup. So his fiance, he died in 2009. His fiance has continued this golf tournament. My family's very involved in it. It went on even during COVID. They didn't shut it down. So it's called the NCCF, National Collegiate Cancer Foundation.
Okay.
And the young people that are looking at college or in college can get on that website, get the information. And Megan, Danny's fiance, we read all of the things that the young people write. I've never known there was this many cancers out there. But anyways, you could have been a baby when you had it. You could be fighting it now. And I just wanted to let you know about it. So it's the NCCF. It's under the Lance Armstrong arm there. And the tournament is up in Maryland, and it's always in October. So this has been going on many, many, many years. And I was telling some of the people, some of the young people that have gotten the money are coming now and golfing in this tournament.
Wow, that's amazing.
And other people have also done like cutting their hair and raising money, and but it's available to anybody around the country. So all you have to do is get on the NCCF website. Danny Wager is his name. He was an avid golfer. So
Thanks
the
for
kids
sharing.
can get money, and they can use the money for anything. So it could be books. Yeah, I wanted to let you know about that.
Lauren, I have a question. Has this ever come up, and I'm gathering it has, what happens if you have an underage patient who chooses a different treatment than his parents or caregivers want,
Yeah.
like legally and ethically, what do you do?
How much time do you have?
Yeah.
It comes up all the time. And I think that's one of the challenges of being a young person, and actually just being any age, that you might have a different idea of what you want for your treatment than other family members. And how do you navigate that? How do you mediate that? No one wants to, I think we see a lot of people trying to protect each other within families because they love each other and they don't want to hurt anyone, but what they want might look really different. And I think we see this especially when treatment options are sort of narrowing and we don't have as many. And I think that it's really a case-by-case basis, and we try to just make sure that everybody's heard and can have a voice. We try to have individual conversations with people and then bring them back together. But yeah, it's really hard. Oh, thank you. Thanks for being here.
Janet?
Oh, another one. Yes, sorry.
Great program, congratulations, love it. But I do have a question. We're talking about people from younger people to 40.
Yep.
What programs do you have to offer for the elderly, like
Yeah.
us?
Yeah. The young at heart.
Yes, the young at heart, and wants to keep up with the young.
Yeah.
But we still fight cancer.
Yes.
It's no different, so.
Yeah, I'm gonna Linnea's gonna talk about that later. I'll just do a little teaser for Linnea, and she's gonna tell you all about some of the incredible programs that we have at UNC for people over 40 like us. I got you. Thanks, y'all.
Thank you.
Next, I want to introduce Fran Colicchio. She is a professor of medicine at UNC, and she has been working with the complex skin cancer patients since 2003. She's actively involved in the clinical trials and all the medical oncology treatment, and she's going to go through things.
Hi. Hi. So Graham.
Yes.
She biked here.
I'm safe, don't worry. This could be a lot, but we're gonna just kind of make it so it's easy. Break it down that way. There are some disclosures because when we do work in this sphere, we get funding for our work through salary support. So those are the disclosures I have today. So when you're diagnosed with melanoma, and I'm going to be specific to melanoma, but I do know that there are some other complex skin cancers that we're treating now, but let's just work on that. We can take questions later. You often are told you have a stage of your cancer. And how that stage is developed is there's your tumor, which is shown there on the slide on the far left. And then based on your tumor, your surgeon might say that you need to have a sentinel lymph node procedure, which means that they're going to put some dye and some radio tracer into your tumor bed and see where that goes. And then take out some lymph nodes and then do a lot of tests on those lymph nodes to see if the melanoma has gone into that melanoma. That's called your N, or your node. And then based on those two things, the doctor might say, hey, now you need to have some scans. And the scans are usually a whole body PET scan. And depending on what institution you're at, you might actually get contrast. Besides just sugar contrast, you might get iodine contrast. That's what they do at Duke. But in Carolina, we don't always do the iodine contrast. And so based on those things, then the doctor will say to you, you have stage 1, 2, 3, or 4 melanoma. But it gets really complicated on whether or not you need to have medicines in addition to those procedures I just described. So to kind of break it down, we can think of medicines for cancer in these 5 different buckets, okay? And so one bucket is chemotherapy. And I just always will say, no, chemo doesn't work for melanoma, and generally it doesn't work for melanoma because melanoma has too many mutations. Most melanomas have been caused by the sun just constantly hitting your skin, and it's just so many mutations that chemotherapy can't deal with it. And hormone therapy has a place in breast cancer and prostate cancer, and we don't have a place for that in melanoma. Target therapy has a place, and the target means that you know which genetic mutation caused the cancer, and you're going to target it with medications, usually pills. Biologics means that you're going to use a medicine that works biologically on the tumor, but it's not immune therapy. Immune therapy, which is the mainstay of treatment for melanoma, means you're going to take that person's own immune system and make it work better. So those are the buckets that we have in our toolbox to treat the melanoma. So let's start with the red one. That's the target therapy. This will be the shortest part of this talk. And what we do is we take the cancer out. It could be the primary, it could be the node, it could be the metastasis, and we send it to a lab. And right now, UNC is contracted with a lab called Tempus, but there's a lot of different labs. So we'll take that cancer and run a genetic profile on that and tell us what gene or genes cause that cancer. And most of the time, these are not genes that you give to your kids, but are genes that are in the tumor. And so you might come back hearing that you have a BRAF mutation, and the most common BRAF mutation is called the V600E, and the next most common one is called the V600K. But there can be rarer BRAF mutations. We can stain for the E, but we can't stain for the other one. That's why we have to check the whole tumor. And we learned about 14 years ago that if we only block BRAF, then patients are going to get a whole bunch of squamous cell skin cancers and feel pretty darn sick. So we have to block BRAF and MEK. So people who get medicines for BRAF mutations get 2 pills. And the pills they most often get are encorafenib and binimetinib, which is called braftovi and mektovi. Or they get dabrafenib, trametinib, which is called Taflinar and Mekinist. There's 2 others, but we don't use them as much because they cause a lot of rash and things. The thing about the target therapy is that they're static. They cause the cancer to kind of sleep, but we're not sure it kills it completely. And there are exceptions to that. So most patients who go on these pills stay on them for many, many years, unless in certain circumstances you're using it for 1 year. And there's a whole long list of side effects, so the dose gets pared down to what works best for the patient. So this slide lists the side effects. Okay. Now we're going to spend most of the time on the green bucket, which is the immunotherapy. We have to spend a lot of time on this slide because people will say to me, well, Fran, why doesn't immunotherapy work for everybody? And there are 5 things that need to work for immunotherapy to work. First, I think, is your systemic immune system, right? And that we know gets worse with age. And that's why COVID was so bad for older people. We just don't have the memory for the virus. That's why we get vaccinated every 6 months. There's probably other things that go into that, your blood supply, how your heart's working, how your lungs are working, but that whole body thing. Then on the top, that tumor genome, that's not the BRAF, but the cancer itself has little genes in it that tell it to spread or not spread, or talk to this or talk to that. So some cancers will really shrink well with immunotherapy, while others will not. Then there's the tumor microenvironment. We spend a lot of time on tumor microenvironment in the surgical oncology clinic because we deliver viruses into tumors, and I'll explain that later. But the tumor microenvironment is that melanoma plus the blood supply plus scar tissue, things like that. And so we know pancreatic cancer can't be treated well with immunotherapy because there's too much scar tissue in the tumor and the drugs can't get in there. And then last is the environment, which is this, how we're all getting along, fabulous nurse navigator, things like that. And then this internal environment, which is your gut microbiome. There's so much immune system in your gut that you want to have a healthy gut. So these things all have to work together in order for the medicines to work well. Here's some biology. It's really important. There's 2 parts of this that are called the checkpoint. That on the far left with the purple cell is called an antigen-presenting cell or a dendritic cell. These are the things that die off with age. So you can't present much stuff to the immune system. But if it's there and talks to a T cell and it says, hey, will you go kill that virus or kill that cancer, it doesn't belong in this human. So it happens and it happens, and then it turns itself off. And that's called the CTLA. The red Y is the thing that turns off the off. And the drug that we use most of the time in the United States is called ipilimumab, or Yervoy. Okay? Always on the TV. The other side is the T cell with tumor cells. So it goes there, the tumor cell's there, it sends those T cells over there, and there's another connection which causes the cancer cell to die. But just like the first connection, it will turn itself off because you can't be on all the time. And so the medicines that we developed to that is called the PD-1 inhibitors or the PD-L1 inhibitors. And there's new stuff. So here's the IPI. Here's the PD-1 inhibitors that you know, nivolumab, pembrolizumab, cemiplimab. I don't have the PD-L1 inhibitors up here. And the new stuff is called Opdualag, Arela Nivo, which is a different checkpoint on the far left. So all that stuff is FDA approved for treating melanoma and other skin cancers. Unfortunately, it's not specific for the tumor, so sometimes side effects develop. And these side effects are mainly the skin, thyroid, lung, colon, liver, and pituitary gland. And sometimes these can be quite severe and sometimes permanent, especially if it hits your endocrine system. So I wish it could be specific, but it can be not specific, and it can be chronic, and it can come later in life. So I'm going to pause right there so you all can catch your breath. And then we're going to talk a little bit about this story, because I gave this presentation on May 3rd, the day all the cicadas came out. It was pretty cool. So I was riding my bike over here, what is that noise? And this is our timeline, and I kind of also laugh about this, because if you know any of these people, we don't look like this anymore. So Dr. Olila's over there, he came back from a meeting, and he said, oh guys, we have to try this thing. And so we did some research for many years on a drug called telemagene laheparethec, and we call it TVAC in clinic. And this is a virus that we use to treat melanoma cancer. And Dr. Moskos came in 2011. And Paula, you see there, she came in 2014. And Dr. Saraz, our newest faculty member, came in 2023. The drug got approved in May of 2015, so this is not new. And we developed a process that we use in clinic to make it smooth sailing. And it's a virus, and it's a herpes virus, so it could cause cold sores, but it was genetically modified, so it doesn't cause the human to get sick, it only causes the cancer to get sick. This is how it's given in the clinic. We're pretty well suited up, and the reason for that is because if it landed on our skin, and then we got to a human who's on chemotherapy, we could cause that person to get sick. So OSHA and Dr. Weber told us to suit up and get this drug. And the way it works is it goes into the cancer, and then it will grow uncontrollably in the cancer, cause the cancer cells to break apart. And then all these white blood cells get in there, and they say, hey, will you come and kill this tumor and kill any tumor that might be out in the body? And so it does that, and has a little bit of effect on distant cancer cells. And if it's on the outside of the body, we can give it in clinic, and if it's on the inside of the body, we do it under ultrasound guided. So that picture is a gentleman we treated during our trials back in 2009. He did great. Unfortunately, his cancer reoccurred in 2019. But he had 10 years without any tumor. And then this person is still cancer-free. We also treated him on our trial, and he had tumor above his kidney too, so it was pretty remarkable because there were no other drugs for melanoma at the time. So I tell you why in a minute why I spent so long on the virus, because we're going to go back to that. But Paula also asked me to talk about tumor-infiltrating lymphocytes, and this is a new treatment approved by the FDA in February of 2024, so it's really great to have new treatments for melanoma. It's a little complicated. The patient's tumor has to be removed from their body, and then the T cells that are part of that tumor get grown in a lab, and then the product is shipped back to Chapel Hill, and the patient is given chemotherapy to kill the T cells that you don't want, so you just have the specific T cells that kill the cancer, And then the patient is given all that stuff along with IL-2, which causes the immune system to go really fast. And so this treatment is not for everybody. And so this is a picture that shows you lots of patients with melanoma, but only one person can get it. Because you have to be strong, you have to have tumor that they can get at, you have to have a strong heart, strong lungs. And there's a lot of side effects, as I was reading more about this for this talk today. A lot of chemo side effects, bleeding, heart, lung. It's not for everybody, but it's good to have another thing. So we have to improve things because we know that these checkpoint inhibitors only help about half the people that are out there, so we need to help more folks. And we have 2 trials that are going to be opening up soon. One is called Ignite-3 and others called Asher Bio, and I'll explain that to you next. Ignite-3 is a virus. That's why I spent all the time on that virus. And it's going to work a lot like TVAC, but it's called a VO instead. So the patients who enter this program will receive VO plus nivolumab, or randomly receive then doctor's choice. And my choice for these people will be the Opdualag in most instances. So this will be a way of testing to see which of these 2 treatments is better, but there's no placebo in this. Everybody will know what they're getting. And if there's nothing that can be reached by the virus medicine, then the other choice will be this trial called AB248. And the top part of this slide shows that in a normal immune system, the IL-2 is activated, and all these different white blood cells get activated, but you don't want all these, because you got a whole bunch that you don't need, NKs and macrophages, and it goes on and on and on. All you want is that CD8 positive T cell with a happy face. So the way this new medicine is going to work, notice the red Y, it's an antibody that will bind to IL-2 and tell it to just stimulate the CD8 positive T cells. So I'm hoping that this will take place instead of tumor infiltrating lymphocytes, that this will be something that we can apply more generally to people. So obviously, you know, this is good stuff, but it's really more about caring. We're caring for you all and taking care of you, part of our family. And just, you know, let us know, me, Paula, Sturgio, Jonathan, and Trish. Anybody know when you need us, we're here for you. Okay, thanks.
So Dr. Calicio, this new TILS adaptive therapy, I mean, a lot of our conversations have focused on cutaneous melanoma. Is that FDA approved for mucosal and or ocular melanoma?
Not to my knowledge, definitely not ocular. Well, do you think it's approved for mucosal?
I believe so.
I'll double check. Does anybody know?
I think it is.
We'll get back to you on that.
It is.
We have
It's approved for mucosal, temporal, cutaneous melanoma, but not uveal.
Not eye. Okay, good to know, especially for mucosal, because that's a tough one. Yeah, Jen.
Yes, I have a question about the new clinical trials that are coming on board. I know in years past, there's been a certain group of people, adolescents, don't qualify for that. And then some of the older people don't qualify. What are the parameters now for the 2 that you
18 and above.
18 and above for the adolescent? What about the older folks?
As I get
Forever.
older, the sky's the limit. So, you know, with age, age is more of a functional thing. And neither of those trials require, excellent cardiac or pulmonary function, unlike the TILs. So I think that more patients will be able to qualify for both of those studies.
Would mucosal be eligible for those?
I don't know yet. I think when we get that open, we'll let you know. There was another question.
Well, you kind of answered it earlier. So my daughter's 17. We got to get her at 18 before.
Yes,
You know,
gosh,
like,
did
what
you
do
ever
we-
want your kid to grow up fast? Yeah. Now, there might be some centers that open trials for adolescents, but it just is a whole different process. I think it makes it harder.
Dr. Calicio, so for the TVAC, which has been so helpful for things that we can feel or see with ultrasound, Did any of those trials pan out where they were trying to like instill it into the lung or
Yeah,
into
they
bodily
use,
areas?
there are some centers that have injected T-back into lung and liver, and I read a lot of case reports on that. I haven't done it because there's been a lot of side effects. So I think it's more tumor deposits that we, still look at. It's okay if you have a tumor deposit in your abdominal cavity, for example, or maybe near your pleural cavity, but I think if it's in the lung, in the liver, per se, it would be a lot of dangerous side effects.
One question, I'm sorry. Brain, what, does that break the brain barrier?
Everything breaks the brain barrier.
Except chemotherapy, some of the chemotherapy.
Everything is so, one of my life careers was to do neuro-oncology. It actually started in 1990. And as I studied the brain, a couple things happened. When your cancer moves to your brain, your blood-brain barrier is no longer great. So stuff gets up there anyway. Now, antibodies have a hard time going into the brain because they're so big. But the stuff that they make, so if they stimulate a T cell, the T cell will go into the brain. So I think that's why people do much better with treatment for brain tumors than we ever thought.
Thank you, Dr.
Thanks.
I'm very excited to present Dr. Scott Chen. He's an assistant professor in our Department of Radiation Oncology. He's a key member of our melanoma multidisciplinary team. And welcome and thank you.
Including me, and really nice to be here with friends and co-workers. Some of you I know from the I'm hopefully not going to spend too much time on this, and one reason being that we don't have as many exciting progresses in radiation oncology as Dr. Hugo mentioned in her talk. But still, I do want to give you a brief overview of what we do and what we offer for our patients. So typically when we consider cancer treatment, there are three main pillars of treatment for cancer. One is surgery to remove the cancer, and two is to use drugs. And when it comes to radiation oncology, we don't really know what we do, and I promise you this is not what I look like at work, only when I'm working on my time machine. So the goal today is to learn about radiation as an important treatment for cancer, and especially for melanoma, and to discuss when to use radiation for melanoma, and also to give you a sneak peek of what we've been working on for the future. So the story of our field of radiation oncology really started in the late 1800s, sorry. The X-ray was discovered by William Röntgen, and this is the picture of his wife's hand. As all good scientists do, we use other people for experiments before we use it. And shortly after radiation was discovered by Marie and Pierre Curie, and they started using radium to treat cancer patients very shortly after. And in 1999, the first cases of cure for skin cancer was reported by a group of Swedish physicians, and these were mainly for basal cell carcinoma, but still cancer being treated, cured by non-surgical treatment was something that was really interesting and exciting. And in 1950s to 60s, we invented machines that are capable of generating high-energy X-rays to allow us to treat cancers that are deeply seated in the body, which really heralded in the era of where we are now. So overall, about 60% of patients will require radiation at some point in their treatment journey. So this is a picture of, I would imagine from the 1960s, 50s, of what a radiation machine looks like. And it bears a startling resemblance to some movies and other apparatuses, which I show now. So how does radiation work? Well, first of all, our radiation machine do not look like that anymore. I'll show you what they look like in a little bit. But first of all, how does radiation work? Radiation works by damaging the DNA of the living cells, mainly in the cancer cells, but also in cells that are surrounding the cancer cells that are normal. So the way we get around with the issue of damaging minimizing damaging of the normal cells is by two ways. One is cancer cells are bad at repairing the damages caused by radiation, while the normal cells are better at repairing themselves. And the other way is, as I will highlight in a little bit, we can really focus on the cancer cells using very advanced techniques and physics and all that. The normal cells not only get a very minimal amount of radiation, but they're also able to repair themselves better. And there are several different ways of giving radiation. One way is by giving radiation in small quantities, or what we call fractions, over several weeks. And the other way is by giving focused radiation using only one or a few treatments just to the tumors themselves. So we, in radiation oncology, have a lot of letters and combinations of letters that you really don't have to know what they are. But mainly what these letters combinations allow us to do is to use the appropriate treatment, use the appropriate technology to treat different types of cancer and treat different cancers in different areas of the body. So this is what a radiation machine looks like nowadays. As you can see, it's much more compact and it's more personal, where the radiation therapist will work with our patients very closely. They will be in the room before and after, and they will carefully set up the patients, and the machine will rotate around the patient's body and deliver radiation from many, many different angles. And it takes usually about 15 minutes, give or take, for each radiation treatment. And afterwards, the patients get up and go. It's just like getting a scan. So I will do these, but focus on the more interesting questions that I sometimes get from patients. First of all, will I be radioactive after radiation? No. So the radiation we give is from outside, it's external radiation. The minute we turn off the radiation machine, there is no more radiation in the room or in the patient's body. Will I become the Incredible Hulk or glow in the dark? To that question, I actually say, unfortunately, the technology to turn people to the Incredible Hulk remains classified. Will I get very sick or lose my hair? It depends. Typically not. That question often arises when I have to treat lesions in the brain, so brain metastasis, for example. Depending on where the lesion is, it can be superficial or deeply in the brain. Sometimes people do get nauseated, or they do feel sicker after the radiation. That can be from the swelling of the tumor or swelling from the brain. Some people do lose some hair, especially if it's given after surgery or if the tumor is very close to the scalp. Will radiation help me live longer? Most of the time, yes, but it also depends. Sometimes we use radiation to help patients feel better, not just to help people live longer. To help people live longer. So there are different ways we can use radiation to help people. So how do we use radiation to treat melanoma specifically? When melanoma is limited to the original location, so if you remember from Dr. Cleachell's talk, she divided the cancer into T and N staging. When the cancer is confined to the original location or to a lymph node area, surgical removal is the main treatment, and nowadays sometimes it's often followed by immunotherapy or targeted therapy or some sort of systemic therapy. A while ago, we used to use radiation to clean up scattered cancer cells after surgery in this type of setting, but nowadays we don't typically do that anymore, except for in very select situations. The special situation I am usually involved in patients' care in cases of melanoma is usually when patients develop brain metastasis. So melanoma has a bad tendency to go to the brain, and brain metastasis is common, and it can be sometimes hard to treat. And as you can see that on the right-hand side, it's an MRI scan highlighting some spots in the brain. And usually we say things that are bright on scans we don't like, usually. And same goes here. You can see with a bright spot here. There is a bright spot here, and there is a bright spot here, and there is a lot of dark area here, so there is probably a tumor somewhere near this area too. So as you can see, some of them are pretty deep in the brain, and surgeons, neurosurgeons can have a very, very hard time getting to them. And I think one of you asked the question of whether drugs get into brain, and I agree with Dr. Cliccio. Sometimes they do, and sometimes they work pretty well. In this case, though, if you notice, the areas around the tumor are what we don't want to see with brain metastasis. They're indicators of the tumor has been growing fairly quickly, and the brain is, and they're causing a lot of swelling in the brain. So typically in these kind of situations, there are two main areas that we need to think about in terms of treatment. One is to make people feel better. And to make people feel better, the thing that makes these dark areas go away fastest is steroids. So steroids can help people feel better, but they do not treat the cancer themselves. And to eradicate the cancer from the brain, we tend to use either surgery or radiation, or sometimes combined. But in this situation, where the tumor is really, really deep in the brain, often go straight to radiation. So in this type of situation, we call this special type of radiation radiosurgery, or SRS. So advances in technology have allowed us to accurately target brain metastasis with precision within a millimeter, so just larger than a couple of strands of hair. Stereotactic radiosurgery, or SRS, or SBRT, or when the target is elsewhere in the body, we use these special treatments to deliver a very high dose of radiation to only one or a few areas in the brain or somewhere in the body over just one or a few treatments. And this machine is called CyberKnife machine. It's slightly different than the one I showed before. As you can see, it's more open space. It's an X-ray source mounted on a robotic arm that rotates around the patient's body and allows the delivery of radiation from many, many different angles. So one thing I do want to highlight is, because our treatment is very, very precise, and it takes usually anywhere between 15 to 30 minutes for each treatment. We don't want the patient's head to be moving around. So one way we get around that, that is by making this mask. And this is a custom-made mask. For every patient who comes in to get the stereotactic radiosurgery, they will have a mask custom-made to their own anatomy. As you can see, there are many, many holes in this mask, and most people tolerate it just fine. It doesn't preclude you from breathing. It doesn't preclude you from seeing things or hearing things. But occasionally we have patients who have trouble with having the mask itself, but we also still have ways to do it. So it's extremely rare that we couldn't do this type of treatment. And this is a great upgrade from a while ago, when we had to use literally metal pins to fix a frame to a patient's head for this type of treatment, when we use a different machine called the Gamma Knife machine. So this is slightly less invasive than having pins pinned to your head. One of the reasons I wanted to highlight the mask is, over the years, patients have been very, very creative in what they do with the mask afterwards. So once the treatment is done, we don't have any use for the mask anymore, and so you can bring them home as a souvenir. And as you can see, many people are very creative in what they do with the mask. I think very young patient who I imagine probably is into Star Wars. So a different type of treating brain metastasis is what we call whole brain radiation. As the name suggests, we treat the entire brain with radiation. We really try to steer away from this type of treatment nowadays as much as we can, because as the name suggests, we have to treat the entire brain, and when we do that, it's usually because the disease is more advanced and we don't have other good options. This type of treatment is usually done over 10 treatments over 2 weeks, so Monday through Friday and Monday through Friday. And it may cause hair loss, dry mouth, memory loss, tiredness, and a variety of unpleasant things that I really don't like, and patients really don't like either. So that's why we try to steer away from this type of treatment. But again, it's one way to treat brain metastasis with radiation. And over the years, we have also figured out that we can spare some of these side effects by avoiding certain parts of the brain using more advanced techniques. One way to do that is called hippocampal avoiding whole brain radiation. And the picture on the left side is the way we historically treated patients with this type of whole brain radiation. And the picture on the right-hand side is what we call hippocampal avoiding whole brain radiation. And typically when we show this type of pictures is to show the difference in radiation dose exposure to different areas of the brain. And areas that are red or more warm in color is usually the area that gets higher dose of radiation. And areas that are cold or more bluish or no color areas that we are trying to avoid. So we can avoid this area called hippocampus very well with the modern technology, and thereby sparing some of the memory and cognitive side effects from this type of treatment. And just as I guess a summary of or extension of radiosurgery or SBRT, we can actually use the same principle of what we do for the brain on other areas of the body. Sometimes when patients present with an isolated area of cancer in their lungs, in their liver, or in their spine, we can also use this type of high-dose focused radiation on these areas as well, without having to resort to surgery. So what's in the future for radiation oncologists and radiation treatment for melanoma? There are studies ongoing that are looking at combining radiation and drugs to stimulate the immune system to fight cancer. So even though we don't have a lot of drugs from the radiation perspective, we have different ways of delivering radiation and trying to achieve a stimulatory effect on the immune system, similar to the viruses, as Dr. Clecho mentioned. So this is one example of patients with metastatic melanoma. On the left-hand side, patient had numerous spots in their lungs. So this is a picture of their lung. This is the heart, this is the spine, and the black parts should be very much black, which are their lungs. After a course of radiation to a different area of the body, and after some immunotherapy, the spots in the lungs actually responded extremely well, and most of them have actually gone away. So we're trying to figure out how that happened and how we can harness that power and use it for other patients. There are other ways of delivering radiation than what I just mentioned. There is a newer technology called flash radiotherapy, which delivers a very high amount of radiation in, well, not a very high amount, but deliver a high amount of radiation in a very short pulse. So typically less than a second as opposed to, let's say, per 10, 15 minutes for conventional radiation. And there are indications that doing radiation this way may actually spare the normal tissue even better than what we have been able to do. So this is an example of not melanoma, but cutaneous lymphoma, and the flash radiation, it went away perfectly, and the surrounding skin looked perfectly normal. So, and there are other things and other technologies, as you can tell from the talk, we really like technologies. There are proton therapy that use charged particles instead of X-rays, and they can really improve the ability of us to spare the normal tissues. And we can use MRI instead of CT to guide the delivery of radiation in real time. They can also reduce side effects from radiation, many to come. So just to summarize, it takes a village to provide the best care for every patient with melanoma and other skin cancers. And as Paula mentioned, radiation oncologists are an important part of the team. We have many ways to deliver radiation nowadays, and many of them have very minimal or very low toxicity, and especially long-term toxicity. And we're working on new treatment options for patients. So I'll stop there and That's good. I'll be here for a while, so feel free to come up and say hi, and thank you.
Thank you. So, if you are a patient here at UNC, you may have heard us say, we're going to discuss your case at Tumor Board. So Tumor Board is a terrible name for our multidisciplinary melanoma conference that we as a team have twice a month, the second and fourth Wednesday of each month. We now meet virtually, and we have a whole bunch of folks that are all involved in patient care, and we present new and challenging patients so we can all discuss what the best option is. So we are going to present a real case study. It's based on a true patient, and I'm going to invite my panel of experts up. Dr. Chen, Dr. Lee, Dr. Calicio, if you're still here, yes. Dr. Gwynn, you, and Dr. Gooch. If my panel of experts could introduce themselves, please, and speak into the mic.
Hi, I'm Jay Longley. I'm a surgical oncology fellow here at UNC.
I think we can skip me.
I'm Paul Googe. I'm a skin pathologist, surgical pathologist at UNC.
I'm Morgan Gwen. I'm the pharmacist in the melanoma clinic.
Y'all know me.
All right, so BC is a 71-year-old gentleman. He works part-time as a financial advisor. He lives locally. He's divorced with 2 children. And we're going to go back in time. In July of 2016, he was diagnosed with a left forehead melanoma. The Breslow depth was 2. Mitotic rate was 1. It was positive for ulceration, and it was staged, just the tumor staging, not the overall staging, was a T3B. 3 from the depth, because every increment of depth gets a different number. 1 being the thinnest, 4 being the deepest, and B because of that ulceration. So Dr. Lee, let's pretend it was 2016 and you met this patient with this T3B melanoma. What would you advise we do next?
So if the patient doesn't have any clinical evidence of node positivity, I would recommend that the patient undergo a wide local excision with the sentinel lymph node biopsy. And the wide local excision would involve excising the melanoma as well as rim of normal skin. And with the depth of 2 millimeters, I would recommend a 2 centimeter margin.
So you would take out the melanoma itself and then 2 centimeters around extra, is that correct? And then take out a sentinel lymph node or 2 or 3.
Yes, how many of it comes up positive with the technetium and the blue dye?
Okay. All right, so this gentleman did have surgery. Thankfully, we got clean margins and the sentinel lymph node showed no melanoma. So Dr. Lee, what kind of follow-up would you recommend for this gentleman who, as far as we know, has no evidence of disease?
So for this type of patient, I would say patient has stage 2 disease, having the T3B and N0 disease. So I would recommend follow-up with clinical exam every 3 months. Can have the patient follow up with a surgeon or dermatologist or alternate every 3 months. But someone should examine the patient every 3 months for the first 2 years.
Okay. Unfortunately, this gentleman did not follow up as recommended, and we'll get back to that later. All right, so we're going to go forward in time. So 4 years later, he returns with a melanoma on his back. And the pathologist called it, they did a biopsy, a shave or a punch, I don't recall, and it was deemed a metastatic melanoma. So this was not a new primary, but it was actually a disease spread. He came to see us in clinic, and Dr. Lee's team did a good exam, and they could actually feel, it says palpable left axillary node, they could actually feel something lumpy and bumpy in there. And they did what they call a fine needle aspiration, where they take a needle right into that palpable node, right in clinic, take out some cells, and lo and behold, it was positive for melanoma. So far we know that we've got, metastatic melanoma on the back and a palpable positive melanoma lymph node in the left underarm area. So we're at a stage 3 now because it had spread to a lymph node. What's this BRAF negative about? How did they test that, Dr. Gooch? We didn't send anything off to a fancy company yet. So how did you figure out this was a BRAF negative melanoma?
With a stain, an antibody stain on the tissue.
Okay. So actually, during our interdisciplinary conference, we'd say, Dr. Gooch, can you show us the slides? And Dr. Gooch actually has the slides. We do keep specimens for quite a while. And Dr. Gooch, can you come up and show us what things look like, please?
Okay. So we keep pathology specimens at UNC kind of forever. But most places it's at least 10 years. The slides and the tissue is maintained in an archive. So you should be able to go back, if things happen to a person with cancer, it's often within that 10-year interval. Sometimes it's longer, but usually within a few years, if not, at least a few years. So we were able to go back and look at the specimens from 2016 and compare to what happened in December of 20. And so actually at the final surgery, the tumor was larger than anticipated based on the biopsy. And so it was, here you see, these are the blue things are cancer cells, and they're infiltrating into the deepest layers of the skin, which are the subcutaneous fat. And under the microscope, we learned to recognize these oval things with the little dots in them. Those are the cancer cells. And this actually has quite a few lymphocytes mixed in, which is something that these days the oncologists like to know. So this is an advanced local melanoma into the subcutaneous fat. So it's a PT4B, meaning it was ulcerated, and the sentinel node at that time was negative. Now this is the piece of the tumor on the patient's back in December, and these are in the upper levels of the skin, but it's just sheets, just lots and lots of cancer cells that look more or less like before. And then we used one stain, the S100, to help us be sure that it is a melanoma. And so this is, we felt quite comfortable this was a metastasis from the earlier arm tumor. Now, it just within a week or so after that biopsy showing the metastasis in the back, this is the actual fine needle specimen. And that's quite a different type of specimen. When the surgeon excises a tumor, we may get something that's anywhere from 1/4 of an inch to inches. And so we usually have, lots of tissue and tumor to work with. The fine needle is just that. It's a hypodermic needle, like a, 20, 18, 20, 21 gauge, and they suck out cells. And then they put that on a slide, and then, so this is, they're lucky to get a millimeter of tumor. And so there's not much we can do with that other than identify that it is the cancer. And these are the cancer cells in that fine needle. This patient's interesting because he's had 2 other primary melanomas besides the big melanoma on his arm and besides the metastatic melanoma. So I think, that's what we all know. Once a patient has had a melanoma, they're at risk for developing a new melanoma. And unfortunately, we see that. And that's part of my job sometimes is to distinguish the new melanoma from the old melanoma. But we're taught to do that with experience most of the time with Gentile. So metastatic melanoma, non-BRAF.
So Dr. Gooch, his final pathology on that arm was much deeper than we anticipated. How often does that happen, that it changes between the biopsy and the final incision?
No, I'd say maybe 10% of the time. It's usually, though, in the physically larger tumors. And so many of the melanomas, fortunately, that we see are small diameter. They're no larger than a dime maybe or a nickel in diameter. And they're not very thick, so they're kind of flat. But some of the tumors that we call advanced primaries, they'll be a mass. You could physically see and feel. It might be the size of a golf ball or an egg or whatever kind of thing you want to compare it to. But it's, this thing you can grab and move it. And those are the ones that we often, much more than we suspect at the time of biopsy.
Thank you.
Yep.
So whenever we have a patient with at least stage 3 disease, again, going to a lymph node, we get a PET scan, which is, as many of you know, a head-to-toe x-ray. And lots of things light up on a PET scan. Not everything that lights up on a PET scan is cancerous. So this is actually a picture of his PET scan. And remember, left is right and right is left. So Dr. Fleischer, you may want to help me, but you've got a hot spot there with the known lymph node. He had pelvic wall mass. He had something in the musculature here. This is bladder, which has the dye. We've got kidneys, which take up the dye, so that's expected. We've got a brain that the whole brain lights up, and we're going to talk about that in a moment. And then there were some lung findings as well. So on this PET scan, we had 3 lung lesions, a possible liver lesion. They saw something, the FDG is the dye that we use for the PET scan, so something lit up on his lower sternum. We talked about the right hip and the left pelvic sidewall muscles. The question is there a brain metastasis? And why can't we use many patients say, well, I just had a head-to-toe x-ray, why do I need to get a brain MRI? Dr. Cleggio, can you chime in?
Because it's all black on that PET scan, so you can't see through it.
Right.
Because all that sugar, the brain is always working.
So as we heard from Dr. Chen, unfortunately, it's not uncommon to have a brain metastases. This is a picture of his brain MRI, and there were 3 lesions that were seen. And the radiologist was very kind. I don't know if you could see, they point out the arrow here, and then there's one in the cerebellum. And I don't know if you can see it, Dr. Chen, because I cannot. Not on this view. Right. So clearly we now have stage 4 disease and we have trouble. All right, now, of course, hindsight is 2020. Back in December, prior to presenting to us, he had headache, nausea, and vomiting, and double vision. He went to the ED and they thought it was food poisoning, and we can't go back in time and know. But wait a minute, I thought we had a negative sentinel lymph node back in 2016. How did we end up with stage 4 disease 4 years later? Like, what happened here? Why didn't we do any scans in the interim? Help.
That's a tough one, Paula. These people with stage 2B and 2C melanoma, their prognosis is not as good as a 3A. It's odd about the biology. They need close follow-up. Whether we really have proven that close follow-up would really prevent this, I'm not sure. think some of that may be just the underlying genetics of the tumor. But we still try. There's guidelines that we look at called the NCCN guidelines, which tell you when to get scans. It's all over the map. I'm constantly looking at it to see if there's any better guidelines. And they'll tell you, oh, you can scan every 3 to 12 months. Well, that's not very helpful. So I think like Dr. Lee said, we just want to monitor and do the best we can.
And there are really no indications with a stage 2 for doing any kinds of scans. And, you know, had he come for follow-up, we probably would not have, he was asymptomatic until maybe he was symptomatic in December. So we don't know. So one thing we do next is what Dr. Guj referenced, which is molecular testing, and there are a couple of companies. We tend to work with Tempest Foundation, one is another company. And he showed one version of the report, this is a different version, and you can see he has a gazillion different mutations unique to his melanoma, none of which we have a medication for at this time. Dr. Guj or Dr. Kalicha or Dr. Gwynn, can you comment on this high MTV and what that might mean?
You're up, Maureen.
So this is that, are we able to go back to the slide from Dr. Gooch? No. So we have the high TMB, and what this is it looks at the mutation burden in the cancer, and when that's really high, it actually has been shown to have better responses to immunotherapy drugs, and so that's pretty good, especially when those are our main forms of treatment in melanoma.
You know, and these different mutations can prove valuable in the future, because what happens, you know, if there's a clinical trial or a drug to target the CDKN2A, sometimes these mutations can be prognostic as well. Okay, so we talked about there's nothing targetable. We don't have our clinical research coordinator on our panel today. Are there any clinical trials for this gentleman? And can you be on a clinical trial if you have brain metastases that may have some symptoms? Does anybody know the answer?
There weren't any trials at that time. The big results came out in 2018, showing that asymptomatic brain metastases does extremely well with ipi/nivo. This gentleman had symptomatic brain metastases, so he would have had to start with radiation. And not all trials exclude patients, but mostly there's verbiage that says if the patient has symptoms, you have to get them through that first, and then repeat their MRI and make sure they're okay.
So Dr. Chen, let's say this patient came to see you and you saw that brain MRI and talked to him and knew that he possibly had some symptoms. What kind of radiation would you suggest?
With only 3 lesions, I would suggest the stereotactic radiosurgery, the cyberknife treatment. It would be only one treatment.
Just one treatment?
Yeah.
Okay. And then how often do you follow up patients after brain radiation, like with MRIs?
I usually tend to do MRIs every 3 months, at least for the first year.
Okay. So we talked about radiation. Dr. Kalicha, you alluded to some systemic therapy, and since he doesn't have a targetable mutation, talked about some ipilimumab and nivolumab. What dose would you do, Dr. Gwynn, if you want to chime in as well?
You're up again.
Okay. So to give some history here is the very first time this combination was studied. It was with the ipilimumab at 3 milligrams per kilogram, so it's based off the patient's weight, and then nivolumab at the 1 mg per kg. And while this worked really great, it also caused a lot of problems with people getting side effects. And so the company said, well, what can we do to maintain the good results, but get rid of some of these side effects? And so that's when they came out with flipping the dose. So the ipilimumab, which tends to be more of the problem child for side effects, they said, what if we did that one as the 1 instead of 3, and then the other one, instead of nivolumab being 1, we do 3 for that. And what it found was that we think it should have pretty similar efficacy, but it lowers the side effect profile. So for this patient, since his brain lesions were treated with the radiation, we can do the lower dosing, the one with the less side effects.
So that's why we picked what we call the flip dose. All right, so he actually did quite well as far as side effects. He had a mild rash, some moderate fatigue. He had this thing called vitiligo. Dr. Gooch, do you want to comment, or anybody, on what it is and why we get excited when people's hair and skin turn white during treatment?
Well, vitiligo is localized loss of melanin pigment in the skin. So if you remember, Michael Jackson had vitiligo, and a number of people. It's actually quite common in the world. But we'll see it in melanoma patients as the theory is that it's a consequence of the host or the body's immune response to the tumor. So the immune system is trying to fight the cancer and also is knocking out cells that have melanin, normal cells, and that so will make white spots on the skin, or occasionally the whole skin will turn white.
We've actually had some people whose hair, eyebrows, eyelashes have turned white. So every time we would give him treatment, we would test lots of different labs, and lo and behold, his thyroid labs, actually both his free T4 and his thyroid stimulating hormone were low. Plus, he had a very critically low cortisol level. We call this hypophysitis. Dr. Collegio, can you comment on a little bit what this side effect is about?
It's actually kind of common with ipilimumab. Under-recognized, kind of common, probably up to about 20% of people. And it's bad. So what it means is that the pituitary gland doesn't function, and so downstream, you don't make cortisol, you don't make thyroid hormone. Cortisol is necessary. If you don't have cortisol, you'll fall out, you'll faint, you can die. So this is a big deal. Luckily, there's a fix, which is you take cortisol, you take the hormone, you take it every day, probably for the rest of your life. I know some of the endocrinologists try to see if the adrenal glands come back. I've yet to see any adrenal glands respond later on. I think it's been a permanent sequela of this. We do a lot of time teaching our patients who develop this side effect what it means. They get a medical alert bracelet that says I have cortisol insufficiency. They learn how to double their dose, etc. So it's a big deal. Sometimes I actually see it without the chemical problem, like someone inadvertently gets an MRI and their pituitary gland is pretty big and boggy, but they haven't developed the hormone problem yet. So you might see us getting your blood checked a lot if this is going on.
So do any of these side effects, are they bad enough that we would stop treatment?
It depends, like, for me, if someone's really got a low gland, I probably would, and what's going on clinically, if the cancer's behaving, maybe take that week off and get the cortisol replaced and make the patient feel better before we restart, but it's not a stopping side effect.
So how did he do? He's actually done quite well. His brain MRI in August of 2021, the 3 known brain lesions have decreased or resolved or nearly resolved, and no new lesions. And his February of this year brain MRI still shows no evidence of metastases in the brain. His CT scan in March of 21, after 3 cycles of immunotherapy, had a good treatment response, decreased size of the lung nodules, and just overall decreased tumor burden, as we say. And his scans in January of 2024, no new masses, and the liver lesions are unchanged over time. So an excellent response to immunotherapy. So here's where it gets a little bit tricky. How long do we continue treating this gentleman? What do we do if he has a recurrence? And is there something magical about 5 years? Everybody says, oh, after 5 years, I'm good. And how did that even come to be?
She keeps looking at me. It's really hard, y'all. There's no answer. You just kind of get to know your patients really well. They need to know themselves really well. You're balancing how much cancer do they have versus what side effects they have. What's their comfort level with going off treatment versus staying on treatment. In the field, we think more and more that once we've created this reaction, it probably stays. There's these memory T cells that stay, just like getting vaccinated. But even that, is a problem. I told you a couple hours ago about COVID, older people need to be revaccinated every 6 months. So do older people with melanoma need to get pulses of stuff to keep their immune system engaged? I don't know. There's actually a study now looking at DNA in the blood for a variety of cancers, melanoma included, it's called cDNA. But whether or not we can use that clinically yet, I don't know. So more to learn, for sure.
And where did the 5-year?
It's unfortunately, it's a myth, there's certain cancers that really does hold up, like with Hodgkin's disease. If you're after 5 years, you're cured. Testicular cancer, you're cured. With melanoma, there are excellent curves that we look at, especially in the initial diagnosis, stage 1, 2, 3. When if you're cancer-free at year 5, it's unlikely that you'll have a reoccurrence. For stage 4 cancer patients who've received ipilimumab and nivolumab, if they're getting out to year 3 or 4, it's very unlikely that they're going to have a reoccurrence. So that's probably where this came from, but it's taken years of study to realize that ipilimumab and nivolumab patients are uniquely different, that they will be okay for many, many years.
And then, so we have this gentleman and the oxymoron of living with cancer. So we think he's in remission, no evidence of active disease. He feels well, he's living a pretty full life, still some mild fatigue. He's traveling a bit, enjoying his family, and as you see, I have to end with a fun tune there. He is working at a pizza place. So he's done surprisingly well after a very dismal initial presentation. Any questions for our expert panel here? Yes, ma'am.
I don't hear that well, but if I heard right, he stopped having the treatments or coming in for anything there at one point, right?
Well, between his initial diagnosis, between his initial diagnosis and then his recurrence, he didn't quite follow up as recommended.
Well, would that have been a possibility if he had it, that he could have avoided the future?
Unlikely. I mean, who knows? We can't time travel, but it would be unlikely that we would have caught some. Maybe we would have seen the back melanoma sooner. I don't know that it would have made any difference.
I know it's in somebody else's hands. Y'all's in somebody else.
Yeah.
But I was just wondering because I've been being seen since 91.
This is true. You're very faithful. We appreciate that.
And I'll see you next
You defy all the odds. Let's just be honest.
Any other questions?
But I think that there's two issues there. One was the issue if you have an early stage melanoma, how often you need to come and what can you use to predict a reoccurrence? And that again is where the circulating DNA thing may be in vogue in a few years. But I know there's a stage 4 patient, and we talked earlier today about the target therapy medicines being static. People that go on target medicines probably have to stay on them for life. Whereas immunotherapy, one of the nice things is you can stop it. So if your immune system stays on, then you stay on. This gentleman was on a lot of immune therapy for a lot of years and then has chosen to go on kind of a maintenance, figuring that he's 70 years old. He takes it every so often.
Thank you.
Thank you, and thank you everybody for participating.
Next, we have Lineberger. She is one of the registered nurses here at UNC, and also patient service manager with the UNC Oncology Support Program. And she's going to talk a little bit about her role.
That Monday.
Sorry, I was a bit of a delinquent and didn't submit my slides on time. So while we're waiting, I'll just introduce myself a little bit more. Thank you. And I really love how Dr. Chen ended his talk saying that it takes a village to care for a cancer patient, and I'll add, and their loved ones. And I get to share a little bit about the other villagers, so to speak, that are just really important on our team at UNC. So we're gonna switch gears a little bit, a lot less science, a lot more about support. And in the areas that I'm gonna describe to you, we're supporting patients regardless of what type of cancer they have.
So we're kind of, jack of all trades and master of none. So I'm super thankful for being here today because I have learned so much about melanoma that I didn't know before. So I'm just really grateful that I was invited to share with you all today. Lauren really teed this up beautifully with her talk about the adolescent and young adult program that is actually part of what I'll call my team, as well as Jennifer Spring. So yeah, I'm Linnea Van Pelt. I'm a nurse. I'm also a massage therapist, which I hope to employ a little bit more very soon. But the job that pays the bills currently is manager of oncology support services. And it truly is a dream job for me. So I'm going to share really briefly, I know we're pressed for time, just a quick snapshot of the cancer support programs at UNC. Now, Lauren shared that visual of the ripple effect when you throw a stone in water. And that can be really positive. You can have positive ripples depending on the nature of the stone, right? Another way to think about the ripple effect is when you throw the stone of cancer into somebody's life, into their pool of water, the ripple effect affects everything else in their life. So it affects the family, it affects their relationships with their family, it affects their finances sometimes in really, really hard ways, and their occupation, the way they think about themselves. Again, it really radiates to the whole life. So we're going to start with, this is a little non-traditional, this is just how my brain works, with two acronyms and then an analogy. So some of you may be familiar with the CCSP, which is the Comprehensive Cancer Support Program. And what that is really just a beautiful collection of people who are really passionate about what they do, and they do a lot of different things, but united in the mission to provide supportive care for our patients and their families. And the PFRC, or the Patient and Family Resource Center, is kind of a magic place in the cancer hospital on the ground floor, where a lot of these supportive care services are delivered to our patients. So you're probably thinking, why the heck is there an umbrella on this slide? It turns out it is a great way to protect your skin from the sun, so I'll just throw that in there. And it's also a great Rihanna song. Any of you know Rihanna? Might not be the right audience for that. So I won't sing it to you. But the analogy of the umbrella is super helpful because it really describes the CCSP, both in terms of kind of how we are joined together and also the function that we serve. So like I mentioned, the CCSP is an assortment of really talented and passionate people. So I like to think of these people and these programs as the spokes of the umbrella. And the fabric that connects them is really the support that we do best as a team or a village. And functionally what that does is help shield and protect our patients and their loved ones along the stormy journey of cancer. Now, if you think about an umbrella, if you put it up in the middle of, a light drizzle, you're going to be fine, right? Most of your body's going to stay dry. If you put it up in the middle of a deluge, your feet are going to get wet, your legs are probably going to get wet. And the point of that is, we can't take the cancer diagnosis away. This part of the team is not in charge of treating the cancer, but we can really form this protective shield to help keep your head and your heart dry, and that's really what we're all about. So the CCSP really began around 2009 by Dr. Don Rosenstein, who's our medical director. So he's a psychiatrist, and he provides specific care for oncology patients. So he really wants to understand and help people with their mental health related to their cancer diagnosis and treatment. And over the years, he added some of these spokes to our umbrella with clinical social workers, psychologists, psychiatric nurse practitioners, and also researchers. So this is really a partnership with Lineberger, which is where all this wonderful research happens, where a lot of our providers live, and the Cancer Hospital, where we take care of our patients. So really bringing that together. But all of this is really focused on what we call psycho-oncology, or cancer-specific mental health care. And then over time, we started adding additional spokes. And this is what our CCSP is today. And you have already heard from a couple of our wonderful colleagues. So I'll just briefly talk through the other ones here. We have a new specific clinic focused on age-specific interactions and support and legal counsel for parents who have cancer and also have minor children. So really recognizing that there's a unique dynamic when you have young children in the home, and how to effectively communicate about your own diagnosis with them. We're doing a lot of work with caregiver support. The name of our center is the Patient and Family Resource Center. As Lauren mentioned earlier, family can look different to everybody, right? It's a very unique thing. So I like to use the term loved one or caregiver. And actually tomorrow we are having our first caregiver cafe, where we will be having breakfast and a time of sharing and connection specifically for our caregivers to come together, meet one another, get some of the resources we have available, get information about it, and really have that time to connect with one another. We have a brand new type of clinic focused on helping survivors or folks who are living with cancer, right? That can be kind of fuzzy. But for those folks who are transitioning out of really intensive cancer-specific mental health, they're not necessarily coming to the hospital, every couple of weeks or every month, really helping them transition into mental health support in the community. We have a integrative and lifestyle consultation service with our integrative oncologists. Has anybody heard of integrative medicine? Anybody know what it means?
And
Would you like to share?
I'll share my opinion, I guess my thoughts about it. Integrative medicine, to me, means integrating positive energy, good things in life, outside of the institutional medication that you're receiving, getting out and being normal again, living your life again, and working on relationships and that type of thing. Eating well is a big one, exercising, and am I right or wrong?
That was perfect. That was well done.
I've been here a lot.
So we have a wonderful integrative medicine, a nurse practitioner she meets with patients and really looks at the whole picture, talks about what their goals are, helps them find ways to stay active, eat healthy, consider other types of complementary strategies to help deal with things like pain and nausea, like massage therapy, acupuncture, and so forth. You heard from the wonderful Jennifer about all the support our dietitians can provide with patients. And we also have a personalized, both virtual and in-person exercise program through our Get Real and Heal program, which is has a not right in the hospital campus, still on campus and close by, but a little less intimidating, and also a lot of virtual care options as well. We have massage therapy, not by me yet, but we have a full-time massage therapist in the resource center who not only cares for our patients, but also their caregivers as well. And then we have, in this more kind of practical resource realm, something called the Cancer Patient Assistance Fund. And what that does is it uses philanthropic funds as well as grants from places like the American Cancer Society to provide really, really practical things, again, to address some of those ripples to patients who are in need, such as gas cards, meal vouchers, paying for hotel rooms, paying utility bills so that their utilities don't get shut off during treatment. And that's a really important service that we're able to provide, again, because we have really, really good support from our community. We also tackle some really like nuts and bolts things, help patients set up for MyChart so they can communicate with their care team, fill out financial paperwork, which is really, really complicated. I sat down and tried to fill out a financial assistance form for UNC Health, and I struggled. And I'm a highly educated professional in the healthcare setting. So this is no small thing, and it can represent a really big barrier for people. So for this and all of these other services, we work really closely with our oncology social work team to ensure that our patients get that full financial navigation. And then we provide kind of the connection point to all of these other services in the CCSP. We make proactive outreach calls for patients who maybe are so overwhelmed by the time they're done with treatment that they just want to go home, but they need something. They want to connect with somebody. Our navigators will call them. We have 30 volunteer patient navigators who visit patients in the hospital, who call patients every Friday just to check in, see if they have medication for the weekend, and provide emotional support. We had one partnership, a volunteer navigator and a patient who spoke every week for 2 years. The patient unfortunately passed away, but that volunteer continued to provide weekly support for their spouse. So really, really profound connection that they made. And like I said, there's this magical place where a lot of this happens. It's called the Mary Ann Long Patient and Family Resource Center. And I like to think of us, back to that analogy, as kind of the, the main support for the umbrella, really bringing it all together. And it's really a special place. So in one way or another, the PFRC has been around for about 30 years. But before we had this big, beautiful cancer center, it was a closet, literally a closet full of resources for patients, community resources, good information, obviously before the internet, where it was even harder to find good evidence-based information about cancer and its treatment. So what we have now still has that resource library. And everything in here is no charge to our patients and our caregivers, including our massage services, including our kitchen, which is full of healthy snacks. We actually run all of that by Jennifer. We even have gluten-free options. We have a hair loss boutique, so anybody with hair loss due to treatment can come and meet with one of our staff and get fitted for a wig, free of charge. We have a dedicated relaxation therapy room. Again, all of this is available to both patients and their loved ones, with 2, soon to be 3, really high-tech, beautiful massage chairs, which, I have some feelings about that, but we also have the real person doing the real human touch version of that, who is available Monday through Friday. And again, I think this is a special place because it's one of the only places in the hospital where anybody can walk in. It could be a patient, it could be a caregiver, it could be a member of the public, it could be a staff member, and nobody's going to ask you what type of cancer you have, why you're there. They're not going to ask you for a copay. They're not going to look at your medical record number. The first thing that happens when you walk in here is one of our staff or one of our volunteers says, "Welcome to the PFRC. Have you been here before? Can I offer you a cup of coffee? I'd love to show you around." And then we sit down and get to know the people that come in and start to peel away those layers and see how we can connect them to support. I went over, I think, most of the services that are unique to the physical spaces here. And for some patients, it's really just having that space to step away from the chaos of their day. It's private, it's safe, it's free. And sometimes that alone is enough to just kind of keep them afloat for the day, which is why I love this quote from a caregiver. The PFRC is a very nice place to rest, find a shoulder to cry on, a person to talk to, and food to eat. Because of them, my life was saved when I started sharing what was going through with my husband. This is somebody who we were able to connect to our counseling team. And the practical support we offer, such as my chart setup, is often not, it's not just like a one and done. We do our best to operate on a relational level with people, not just a transaction, but using every opportunity, every question, every need as an opportunity to really figure out who that person is and how we can help them. And the great thing is you don't have to be a patient in active treatment or even know what you need necessarily. You don't have to have a question. All are welcome here. And what we're really trying to do as we move forward is use this space and our people to build community. And that's patients before, during, and after treatment. It's their caregivers, it's advocates, like some of you in the room here, that are continuing to kind of weave that safety net for our patients as they travel through this journey. So please stop by, please reach out. I'm available by email or by phone, or if you just want to wander in and say hi, please feel free to do so. And I think I'll leave it at that, but happy to take any questions.
The Caregiver Cafe.
So this is, a newer thing. So we're doing kind of a soft opening tomorrow. We have flyers up in the clinics, but we are working with our communications partners to broadcast it more fully. It'll be on social media. It'll be on the TVs up in the clinics and infusion. So we're trying a multi-pronged strategy. The advertising is a challenge. It's something that we're constantly thinking through how we can do it better.
That was very helpful. Thank you so much.
You're welcome.
This is a very special part of our program where we invite, or I've invited several patients and one caregiver to come up and share their stories with us, and so we can feel that connection that Linnea was talking about. So Mr. McClure, Ms. Fay, and Mrs. Nemeth should be coming up. Unfortunately, my other patient participant has COVID and is coughing at home. Did not come today. So, it takes a lot of courage to say yes to Paula when I ask them about this, so I'm very grateful. We all met on Zoom so we could get to know each other, and I could kind of prepare them about what we might talk about. So you can all just start by introducing yourselves and just saying a few words about anything you want to share about your experience.
I'm Karen Nemitz. I'm a caregiver and started this journey here. Interesting, I just reflected this morning, it was 7 years ago, brought me here. My husband had gone out, he and I and some couples had gone out for dinner, and all of a sudden he started slurring his speech. But then he had dental work scheduled the next day, and he said he's not afraid of going to the doctor, so I believed him when he said, no, it's just something for my dental appointment tomorrow. Anyway, long story short, by the time we got home, he was struggling to put his take his shirt off, and I could tell something was terribly wrong. And had him do looked up on the internet and it said, hold your hands over your head and all this stroke stuff. He passed with flying colors, but still there was something wrong. So took him to Rex Hospital, and they kept him, and he ended up having a melanoma tumor that had pressed onto his blood vessels, so it was a slow blood leak, I guess. Anyway, so it began. We ended up being referred to here after he had surgery, and at Rex, he came here, and I met the nurse navigator. Whoever came up with that program, kudos to them. It was whole level of stress away from the entire, to know who you could go to, because you had no idea. I didn't know many of these. Well, the funny part is that, I'm going to story, I'll just do it quick. I had been diagnosed myself with Parkinson's 2 years prior to this, and breast cancer prior the year before that. So I know a lot of these hospitals really well at this point. But the navigator process was excellent. It took a whole lot of the stress away, and I'm very, very grateful to that. We're going to talk intermittently. So
Yeah, we'll go back and forth.
back and forth. Okay. So
McClure, do you want to say a few things?
Sure, I'm Joshua McClure. I was diagnosed in 2020. I was basically asymmetric. But when I went in, I had stage 4 melanoma. And within a few weeks of getting diagnosed, I was in a wheelchair and couldn't get out of bed by myself. Had cancer down my spine and my hip bone and my shoulder blades, and went to a local hospital, and they were diplomatic about it, but basically said, we can try to keep you comfortable as you die, and prepare for a funeral. And it wasn't my vision. Had a 2 and a 3-year-old girl at home, along with my wife, and so we tried to get into UNC, and I think we shared that when we met, that my vision is to live. I want to do everything possible to live. Got these old girls I want to be there for. And what a phenomenal experience with the Nurse Navigator program, and just the care that we received.
I probably don't need them. I was diagnosed, it was just a year ago on the 15th. And mine didn't start on my skin. My melanoma started where the sun doesn't shine. So I guess I'm just a ray of sunshine on my own. And it started, I was having some bleeding and some pain, and they referred me for a colonoscopy. Colon cancer runs in my family, and so I was worried about that. And when I finally got a referral, they couldn't get me in right away. It was going to be a few months. And because I had colon cancer in my family, I was like, ooh, I don't know how I feel about that. And I went back to my primary care physician, and I was like, you know what? Refer me to as many people as you can, and whoever can get me in first wins. And so they got me into somebody within a couple weeks, and getting the results back from the biopsy was a little bit difficult, but I got the results back, and that gastrointestinal doctor, I'm not sure what those are called, he referred me to just a general colon cancer oncologist. And when I played Dr. Google and looked up what mucosal melanoma was myself, I was like, ooh, I don't know if this is right. So I went back to my primary care physician, who knows me really well. I've been there for a long time. And between the doctors there and their staff, they contacted Dr. Colicchio's office, and one woman spent an entire day getting in touch with you guys, and I really feel that saved my life. And so that's how I ended up here, and it's been a little bit bumpy, but overall I'm doing well.
Many of my patients can tell me exactly where they were what time it was, what aisle they were in the grocery store when they got the news of that one word that changes your life. Did you have that experience of?
So getting the results was taking a long time. And so I knew it wasn't good, or at least I felt it wasn't good. I don't know if it was intuition or what. And so I actually belligerently, I'm a good advocate for myself. Paula will attest to that. Sometimes I can be a bit much, but in this case, it worked out well for me. And so I ended up calling and finally getting them to call me back, and I was at work and I was like, okay. I'm like, I'll just compartmentalize this and I'll just go back to work. And within like 20 minutes, I'm like, I cannot do that. I need to leave. And so I did, and that's when I reached out to my own primary care physician, and they worked really hard to get me to you guys, and I am very, very grateful for that.
Mr. McClure, you shared with us the other day that you had the pandemic to deal with as well.
I think that made it especially hard for me when I got the original, because I'd gone into the dermatologist, and because the lymph node was swollen, or thought it was swollen, it was a tumor. And my wife couldn't go in with me. And so when I got the news, you have cancer, I just remember feeling so lonely, because she was sitting out in the car and I'm in there, and she's just trying to watch what's going on the phone, and I just felt like I needed somebody to hug. So that was definitely something I'll never forget, just that feeling of just feeling very alone.
I don't know. I think part of the thing that helped me was that I was just ignorant about all things science and medical. We didn't have doctors in our families, and so I'd had fairly good health up until the whole other diagnosis. So everyone was very helpful. Paula was especially helpful, because she said, do not look up anything on the internet. Just don't. She said that this cancer has had a whole lot of improvement in the last few years. So whatever you read there is going to be unimportant at this point anyway. So that was good advice. And the rest of it was, we really didn't know much. So I tend to be a very positive person anyway. And so I just thought, all right, I'm just going to keep going. And that's what we did.
Thinking about, people in your world, friends, families, professionals, what has been particularly helpful or what has been unhelpful? Things that you wish you could tell healthcare providers, like, please don't do that again, or what has been really helpful to, anything?
Well, as I said, you were helpful, and I found there's a couple of other groups that utilize this patient nurse navigator, and I can't say enough good things about it. Also, friends have turned out to be exceedingly important. We moved here 20 years ago, but knew nobody, absolutely nobody in this town. And we've made wonderful friends since then, and our family is far away. So we ended up with casseroles at our door. A friend, it was just amazing how friendly and kind. And it made me appreciate how important it is to do that for others as well.
I can definitely say the same, that just the village of people that just seem to come out of nowhere, bringing meals, sending cards, calling to say, hey, we're praying for you. Just so many people just stepping up, even people I hadn't seen for years and years, from college, just contacting. And that's something that changes you, makes you aware when somebody else gets a diagnosis, what you can do, and that those little things matter. Especially when someone doesn't say if there's anything you need, I'll help, but if they'll say, people would say to me, hey, do you need any repairs on your house? Or they give me like specifics, and I always try to do that if I'm helping somebody else. I can do this or this, can I do that for you? And that they mean it, and there's so many people like that contacted us, and it just really touched us and impacted the whole family.
Similar, I had, friends and family, and my husband's been amazing. My employer has been amazingly supportive. I work in education, so I'm an elementary school teacher, so I've had a lot of appointments. I've had a lot of days I've had to miss, and they have really, my coworkers and everybody have worked to make this work and help. For those who have mucosal melanoma, there is one group that I know of, and that's the Mucosal Melanoma Warriors, and they have a website and a Facebook page, and that's been really helpful because there's not a lot of us who have it start not on the skin, so it was helpful to find other people and hear the treatments they're on, or the trials they're doing, or the things they're doing. And then, like everyone said, Paula's amazing and has been wonderfully helpful.
So a lot of times I'll ask patients, especially as time goes on, you think about your cancer every day. And for Mrs. Nemitz, I would say, you're quite a few years out from Mr. Nemitz's cancer. If he sneezes funny, do you worry? Do you keep eagle eye on him? And if anybody felt comfortable sharing?
Yeah, it's an interesting question. We don't think about it every day, but there are times that it pops up. We had a recent situation, and all of a sudden, Mr. Nemitz started planning his funeral and going through all kinds of things. I said, not yet. So he's calmed back down, and we're all back to getting the dog for a golf cart ride or whatever else he does. But one of the things that I thought was helpful for me, and I have to admit, I started this a little bit before this all happened, but it helped, was a gratitude journal. That every day I sit down and write down 5 things that I'm grateful for in the middle of all this. And it's just changed my perspective so dramatically. It was really, really very helpful. Think about what's positive and just out of anything, even with all these diagnoses, going from Parkinson's to breast cancer to this, you say, thank goodness I live in an area with hospitals like we have here. Thank goodness for the people that have gone before me that have done some of the clinical trials and all. So that's been very, very positive.
For me, I had obviously amazing results going from being in a wheelchair, not being able to get out of bed, and things like that. My pancreas, I did get type 1 diabetes, so I have an insulin pump, and so that caused a lot of, you have to think about it a lot and check your insulin, all that stuff. So in that sense, I think about it every day, but otherwise, it's not something that I worry about. I just try to move forward. Things happen in life, and I think about it, but it's not in a negative or positive sense so much as it's just part of what's created my life. And I've just tried to keep moving forward. So been blessed. This was in 2020 when I was diagnosed, and then I got the clear PET scan that same year. And I've had clear PET scans since then, and I now have another little boy. He's 2 years old, so I got 3 kids. Just found out that my wife is pregnant, so we're going to be having our 4th. So both of us have chosen just to move forward as a family, and I think that's the best way. I'm just enjoying life and so grateful to be here. So grateful to be doing so well.
I guess I'm just sort of getting to the point where we're talking about when we're stopping treatment, and so it's a little fresh still right now. So I guess at this point, yeah, I do right now. My side effects are very, very minimal, just very, very annoying. So I dry mouth, so I drink water constantly, which also means I go to bed. So that sort of keeps it in the front of my mind, I think, and then there's some other things, but overall, I'm grateful for where I am. I'm not planning my funeral or anything.
I truly appreciate your being here and your honesty. I didn't know if anybody wanted to share or had any questions or feedback.
I just wanted to tell the lady that was talking about the different programs the UNC has. I go to the Get Real and Heal, Do that twice a week. It's great.
Yes.
Thank you for sharing.
To the gentleman, did you have surgery? Did you have radiation or was it medication? That was your treatment?
Everything but radiation. So the first step was to have lymph nodes removed because that's where they saw it. So I had 17 lymph nodes removed in a 6-hour neck surgery, which was also hard because it was during the pandemic. So again, my wife couldn't be there, couldn't spend the night with me in the hospital, all that good stuff. And then did the immunotherapy.
Done very well.
Yeah.
Andy?
Yeah, just had a question. So just like, with science, we're always trying to improve things also for support for patients and caregivers, as you know, work really hard to do. So I was just wondering throughout your journeys, because it seems like you're all kind of different stages throughout your journeys, was there anything that you wanted or needed in ways of support that you didn't have or that you wished you had?
I think for me, I was just so blown away by the support. It's hard to say that anything was wanting in any regard. I think offering specific help that you're willing to give, I think was especially important to me because everybody would say if there's anything you need, and that kind of leaves you wondering, do they really mean it? Does that mean I call them up because I have a leak in my roof, or what the person that said, any house repairs, I want to do that while you're getting treatment. Okay, I'm calling him for that. And then I think sometimes people can be quick to give medical advice when they don't know what they're talking about. That can be quite frustrating if they had an aunt that ate something or another, and that cured her of it. Yeah, so just refraining from doing that. I try to be respectful. People have different views on how they're going to do their own treatment. So I try to just be supportive when it comes to that and just offer what I can do to help them with that. As much advice as they could or should be doing.
I agree with what you said. I think that, first of all, locally, like we said, we've met a lot of wonderful people that live in this area that give but also the hospitals and the departments have a lot of resources that most of us have no idea are out there. So
that's true.
It's great when you find it, but I can see you do have an opportunity to, as you were mentioning things that, oh, I didn't put that in. So.
All right. I think the only thing that I guess I wish was, I don't know if it was unhelpful, it was helpful. I had some visits to the ER who were slightly traumatic. I think that if there's I don't know, communication between, because immunotherapy is different, and they're like, oh, you're on chemo. I'm like, I'm not on chemo. And I had a rash, but I was also camping, and it really most likely was bug bites. And if it wasn't bug bites, it was probably from the immunotherapy. And then they're like, you might have meningitis. And it turned out that I guess immunotherapy can induce meningitis, and I didn't know that. And there wasn't a lot of communication, and they're like, here, we're going to inject you with this, and we're going to give you this. And I really didn't feel like I knew what was going on or why they were doing things. And I think that would be one thing that I would think it would be helpful is because we came here to the ER, not by my house. I could just see where the one by my house wouldn't, but I guess I assumed that since it was here at UNC, they would have, I don't know, there could have been better communication maybe.
No, I agree. I think, in life and especially in medical care, it's all about communication, and we all can do much better, especially between departments. So I appreciate your honesty with that. And so thank you again. Again, I'm very grateful for your being here. And we have one more speaker. Do you want to introduce the next gentleman?
Honor to introduce Dr. David Alua, and I'm going to read his titles here because he's got many. He's the James and Jessie Millis Distinguished Professor of Surgery, co-director of UNC Melanoma Complex Skin Cancer Program. And probably his hardest job is he's been my boss for the last 22 years, so that might be his most challenging job that he has. But come on over, doctor.
I think the title of boss of you is an oxymoron.
Supervising physician, I don't know, but we've worked together since 1998, but 22 years as his nurse practitioner. There you go.
Last year, this is a repeat, because some didn't attend last year. And that's okay. And the part that I want to get through, especially with that title, is you may feel like people don't know what's going on. Imagine how I feel, or Jaywan feels, or Trish feels, or Paula feels, when next week at ASCO, or 2 weeks from ASCO, the national, international, big medical oncology, surgical oncology, radiation oncology meeting, is there are at least 2, if not 3, presentations that are gonna probably change everything I'm about ready to say. So Morgan's over there smirking, so she may have inside data and she's not allowed to say anything, but it's true, right? So I know we've heard a lot about this. Not any of the people I just named. When was the first immunotherapy drug approved for use in the United States?
10 years ago.
2014.
2011. So we're talking about only 13 years, and that was the first drug, okay? We're now up to 11. And so if you think some of these, I know you, where is she? I know you use communication issues. I actually think it's a knowledge deficit, right? Because if you were, you didn't have any of the ibs and abs. All these drugs are completely new to the family practitioner. They're completely new to the emergency room physician. So how they get incorporated is really difficult. So I'm gonna go back, and since I'm a surgical oncologist, this is what I feel my life is. I mean, and maybe one of you walked into my office and said, that's not what you said in your 2018 paper. And that's because I've literally written manuscripts that contradict previous manuscripts that I wrote. And so for anyone, if you're not a lifelong learner, the field of complex skin cancer is not for you. I'm serious. I mean, you guys may not realize what Paul Googe brings to the table. The breath of fresh air of Paul Googe as a dermatopathologist, questioning where is this, whether it's a cutaneous or mucosal melanoma. This is why we come to work every day, okay? So this is what I feel like, and Jaywan's sitting here going, I have no idea where this talk's going. So this is me, and I don't think Jaywan and I have had this conversation. But I was a trainee at Riverside Methodist Hospital in Columbus, Ohio. 1995 was my graduating chief year, so I was there for 5 years. I did one melanoma case. One melanoma case. And I've got a picture of Kim Hammelberg there. Median survival for a patient with stage 4 metastatic melanoma, that means the average life expectancy, 6 months. That's it, right? And literally, if we fast forward to 2011, that's the same answer, because there's no advancement. But I think I'm going to fellowship and I'm gonna learn new things. J1's learning new things, right? Trish tries to think she's learning new things, but she's an old dog that doesn't like to learn new things, but we're going to, right? I mean, God, I knew it. Mrs. Edmondson, you can say anything you want at any time, and if we need to bring a mic to you, we'll bring that to you, okay? But my point is, right, if I've got something new, and we find out we're gonna do something new, let's figure out how to apply it, and that's why I went to fellowship, right? And so, for any of you that have seen anything, right, that's one of the blue sentinel nodes, right? Pioneer, passed away actually from treatment for his lymphoma of cardiac failure. But that's what it was. Great. Still the same median survival. Us being able to do the sentinel node didn't actually change survival because we didn't have a systemic therapy. All we were able to do was identify disease earlier, but we weren't making any impact in survival. But at that time, right, you had a positive sentinel node, you took the patient back for a completion dissection, and then you would put them on what I thought was one of the world's worst drugs, interferon alpha-2b, which was basically just giving patients side effects with no benefits, but that's what we did. Then they would go to stage 4, and then they go on a clinical trial because we didn't have any FDA-approved drugs that worked. And the flip. Now here I am on the roller coaster again, right? So here we are, we do the sentinel node, we find it early, we do the completion dissection, and then we're hoping we have an adjuvant therapy, but lo and behold, we now have data that if J1 would answer complete dissection on his surg-onc boards that he's gonna take in a year and a half, he'd fail. Because you don't do completion dissections routinely anymore, right? You have to pick and choose which patients are gonna do this. So completely different mentality now. Because the volume in the sentinel node, right? So if anyone's ever read their pathology report from Paul Gooch, you'll see the preciseness of the size and the number of metastases you have. And that starts to drive prognosis. That may drive whether or not I need to take you back and do a completion node dissection, but in general, most people don't get a completion dissection, right? Routine, J1 fails the test, or fails the question, okay? This is the game, this is why. If you feel like we're changing on you, if you feel like something is not the same as it was 2 years ago, it's because the field of immunotherapy is running so fast. And if anyone in the room fails to realize the reason why, immunotherapy is so incredibly lucrative that drug companies are stumbling over themselves to find a next in class or a new class. And so we've got a balance of therapeutic progress versus financial toxicity. And I'm sorry I didn't walk into through. Did you have anyone talk about financial toxicity? Maybe for next time. 1 dose of immunotherapy, 4 doses of 1 immunotherapy. Anybody?
40,000?
That's ridiculous.
You wish.
I think it's like 40,000 for one.
I saw
Right.
40,000 on my bill one time.
That's right. So
for like-
when the drugs came out, for 4 cycles of a PD-1 inhibitor, Nivo or Pembro, $250,000. Right, so imagine you're on an 80-20 drug plan. So really, really efficacious drugs that have side effects, and they also have financial toxicity. We're gonna talk more. Back to when I was now a fellow, right? Because I'd only seen one melanoma patient in residency. Now I'm into fellowship, and I am just inundated with metastatic melanoma. Inundated. And as I've told you, we didn't have any immunotherapy, we had no drugs that worked. So guess what you do in a surgical oncology fellowship? You cut it out. And right, we used to have a saying, if the surgeon can't cut it out, the melanoma patient's in trouble. Okay? And this is really to give you framework of how poor the drugs were. Okay. Dacarbazine, which is DTIC for people that know in a different way. Can you imagine you treat 100 patients to have a complete response rate of 3 to 5%? You're not even going to get a drug approved right now in melanoma for that. DTIC is so old, and Trish is going to say, how old is it, David? It's not as old as you, David. It was grandfathered in. They didn't know, the FDA didn't know what drug to put in the melanoma bucket, so they gave us DTIC. Interleukin-2, for any of you that have had interleukin-2, a little bit bigger complete response rate, had to be taken care of in the ICU. Patient had to be in the ICU because of the profound hypotension, low blood pressure. Okay? And I mentioned my hated drug, interferon alpha-2b, had disease-free, which means you last longer without a recurrence, but you die at the same time. So you incur all the side effects just to push off the recurrence, but you still pass away at the same time. No overall survival advantage. This is why the surgeons, why we took a dominant first in line place for dealing with people, is because if we could remove all of the disease, complete radiographic physical exam findings, if we could remove it all, it was shown over and over in single institution trials that they had a better end result than if the surgeon just relieved a bowel obstruction or just took out part of the tumor. So it really behooved people to find and back up a surgeon that he or she knew how to remove all of these different metastases. Now the immunotherapy is here. Now what do? I've got a person who's sitting in my office with a single metastasis, in the liver, and now I've got all this immunotherapy. I've got a single site of disease in a distant lymph node. What do? It's really clear though, and this is that first trial that was published in 2010 and FDA approved in 2011. And you're not going to think that this is very exciting. But at that big meeting that I told you, people were standing outside the door. I called them the seaters. If you walked out, if one person left the meeting, the melanoma meeting that year, then they would go seat you, right? Because there's fire code issues. That's how much of a buzz it was, and it was only a 4-month difference, right? 4 months, think about it, 4 months. Contrast that with all the years previous at this big national meeting, the melanoma surgeons, medical oncologists, radiation oncologists would argue who had a more negative trial, meaning who had the worst results. It's because we didn't have anything. This is the start of the beginning. I didn't update this, and I apologize. It's now been updated. But now, in 6.5 years, the overall survival of a patient taking IPI plus Nivo is 49%. Think about where I just started. I started with saying that the median survival for stage 4 metastatic melanoma is 6 months. And now I'm showing you in a prospective randomized trial that the 2-drug combination, patients are living 6.5 years, half of them. And this seems to be just slightly sloping off, but it's out to 7.5 years and almost equally as good. If you are sitting in the audience and you got single agent PD-1 inhibitor, you've dropped a little bit and didn't incur the side effects of IPI. And then if you had single agent IPI, it's the worst. But still, think about that. I'm telling you it's the worst, and 23% of people are living 6.5 years. So even though we sometimes talk about the CTLA-4 inhibitors in a negative light, it is sure light years ahead of where we were. Oh wait, now what do I do? Now what do I do? So now I have effective agents, and we've been given those effective agents in the stage 4 patients, right? As defined by having a distant met in the bowel or the liver or the lungs. Take it earlier. If it's working in the stage 4 patient, why do we have to wait that long? Bring it earlier to the stage 3 patients who have nodal disease, right? Present with a palpable mass under their arm, a melanoma on their back, put a needle in it, prove it's stage 3, and instead of leading with surgery, yet again, lead with the drugs. And if you lead with the drugs, you actually gain biology. You actually know if you've been successful at making sure that patient's immune system is revved up. Because we're going to eventually still get to surgery. The magnitude of the surgery may be much smaller, but we're going to still get to a surgery. This is just one small trial that gives credence to leading with drugs. This was before robust immunotherapy was around, but it's clear that you do surgery, you're going to get a result that's favorable. You do immunotherapy, combine them, we're going to get a favorable result. So now somehow we have to figure out the timing of immunotherapy and surgery that's the right for each individual patient. This is why it becomes so confusing. This is why we talked about communication at multiple times today. This is why we have to have medical oncologists, nurse navigators, nurse practitioners, PharmDs, surgical fellows, surgical oncologists. They're all talking to each other. Because we have to order, and I mean order of operations, and not surgical operation, order of therapies for an individual becomes critical. And for everyone in this room, you may be going, yeah, but in 2020, you did this. It may not be the same today. And it may not be the same next year. Paul has me back again. But I just want you to know that this field is so exciting. It allows us to do that. And I haven't even touched on some of the other things that we do. For those of you that are survivors of TVEC or injectables. It's another great thing, another way to get immunotherapy into people. But this is just an incredibly exciting field, and melanoma and cutaneous oncology is literally leading the way. Can argue maybe renal cell is doing as many exciting things as we are, but this is a pleasure and very fulfilling. So with that, I will tell you that I am on the roller coaster, and I might completely flip this talk next year, but it's been a pleasure. Thank you to Trish, and thank you to Paula for having me back again. Yes.
I probably already know the answer, and there isn't one, but, so you do the neoadjuvant, and then you do surgery, and then you do some more immunotherapy for health.
Ooh, I didn't say, you said that, I didn't say that.
Okay, okay.
So, there's a lot of evidence that's building that if we lead with immunotherapy, do a surgery, and get a complete pathologic response, meaning no viable tumor cells in the surgical specimen.
So it does have clear margins.
No, nothing in the specimen. No viable cancer cells anywhere in the specimen. No immunotherapy afterwards. You can even go from, and this is another reason that Paul Googe's path reports are so important. You can also make a great argument that a patient who has a near complete response is defined by less than 10% of the tumor cells are viable, no additional immunotherapy.
What if there is tumor cells and they are viable?
Well, then it's the amount, right? So I'm giving you 0 and 0 to 10%. Probably don't need, not probably, you don't need any more immunotherapy. Someone has, 20%, 30% for viable tumor cells remaining, of course, they're going to get more immunotherapy. Then the question becomes, which agents, right? Because if you've given whichever combo or single agent, do surgery, and you don't have a complete response, probably need to make the argument you need to do a different immunotherapy after surgery. Does that make sense? Okay. Yes.
Mine was back in 2014, so now, when you do the surgery, you resect the sentinel node, and that comes back negative, but when you get in there and the tumor's bigger and it has reached the lymphatic material, do you now consider sometimes doing immunotherapy?
Absolutely. Okay, so now, what I think you're probably describing is someone who has satellites or in transit disease in the tissue. And that correct staging would be 3B. And so, forgive me because I'm not going to remember if 3B, that would have been 3B in 2014. But that's 3B, and we have good evidence that single agent immunotherapy would be advantageous for a 3B patient. Okay? Preferably with IPI or, preferably with Nivo or Pembro, a PD-1 inhibitor, but absolutely. Okay? Now, again, you guys must think I'm just enamored with Paul Googe, and I am. But he has the way of his wide excisions, because Trish and Paul and I have seen lots of different path reports. The level of scrutiny that he and Jason Maidema do to look for satellites, to look for because they know it changes a patient's stage and therefore could lead to a different course. So absolutely. Do you have any questions or thoughts?
Great job, thank you.
Very good.
Go on.
all for joining us, and we're very, thank you for letting us be part of your lives. Again, if you can do the evaluation, we'd be most appreciative. You know how to reach us if you have any questions, and safe travels home. Thank you.
Do not have